it's not right to say the man behind this activity is Dr. Saraf. I'm just giving a platform for all the partners. The idea was coming from where we are sitting on the table. Discussing this around 3-4 months ago. I think we need to realize Pakistan had always been reactive to the international changes, whatever happening in the health system. We always were laggards. We were followers, laggards. We never came out at front and did something which then would be led by some other country. So we, fifth largest nation, nuclear nation, one of the largest Islamic country, and not setting precedents and a good example for other countries. This is again very late. I will say we are doing it today, although, but it's many years late. I had been traveling around, and all of the people sitting around the table, they must have been visited countries, very small countries, and some very developing countries with much better IT use, much better technology use, much better technology use in health sector to gain efficiency, to gain quality. In health system, we call the 6 building blocks, but in Pakistan, we are struggling with the only building block, which is human resource. That's it. We are worried about doctors, nurses, paramedics, and all of that, and the jobs for them. We're not worried about patients. Pharmaceutical is one, which is mostly driven by the private sector, corporate sector, so it is being taken care of. So pharma business and pharmaceutical has advanced at a very high level. Whenever a new drug is discovered globally, it reaches in Pakistan within, say, 24 hours or 48 hours. Medical technology, I don't know why, but this is one of the most cost-intensive cost center in health system. In future, it will become even more proportionately much higher slice of the whole health system cost. So the salary is one, medicine is two, and the technology will take over and may become one of the most important determinant of the quality of care. So in future, where we are anticipating a lot of HR and a lot of physicians and a lot of health workers going obsolete and replaced by machines. So artificial intelligence, machines and technology, they are the future, whether we accept it or not. We usually do not accept and ultimately we then follow. So first we need to anticipate, we need to plan, and then we need to do something about it. This is a very small level activity. It was supposed to be online, most of it, but then Awais Saab and myself and Razna, we discussed that we can invite some of the people who are doing a lot of good things in Pakistan. They can come and present, they can see what is happening. So if you see the agenda, you will find a lot of international speakers as well. These are the ones who are known internationally. And it's a great, I will say, a great success by DMC and Awais Saab and all the colleagues that they are today speaking at this occasion. And hopefully, what we have planned is after this event, we will take note of the key messages from each of the speech. So, this is going live on Facebook or YouTube or whatever. So we opted for more audience who may not be coming to Islamabad or coming to HSA, but they still can manage and they can join and they can see Facebook Live or YouTube Live. So we wanted to send a message that out of these 6 building blocks they mentioned, and just focusing on one, which is human resource, we are neglecting a lot of other building blocks. Medical technology, this is one separate building block, along with medicine and drugs and logistics. Medical technology is the one which will shape the future health system. So if we, the 5th largest and 240 million plus people, we do not take benefit and take use of technology, we will be still struggling with the problems of quality of healthcare and efficiency in healthcare. Technology is always there, not only just to improve the quality, but also it gives you a lot of efficiency. And our system, Pakistani health system, is one of the most inefficient systems. This is the most costly system if you talk about the inputs versus process and output. Look at the inputs going into the system, 1,207 billion rupees every year. And what are we, all of us on the table getting out of it? Nothing. All of us go to the private sector, 30 of us. We buy, we purchase, and we do what we call it in the power shape, you could call it health shopping. So we do shopping and we don't get whatever is in the system. So the processes are to be improved, the system efficiency has to be improved, and the quality is definitely for improvement. So what we planned is we wanted to have sort of a roundtable discussion. A lot of people came, and then within the group, we created a group 3 months ago. Within that group, we thought of that we all of us, which don't know much. I at least don't know much about medical technology. So if we start talking to each other with little knowledge, we will not reach anywhere. So we thought that we should connect ourselves to someone who is doing good in the medical technology somewhere. So Germany, South Korea, you see the program, you will find a lot of people from Norway, Finland, and then Pakistan is as well, but most of them China and Germany, South Korea, Turkey, Singapore. These are the people who are doing a lot. And imagine, we are the needy ones. We are the needy ones and we don't care. That's a strange phenomenon. We need all of these and we are just sleeping, we are waiting for someone to give us something. And these people, when we approached them, they were so proactive to ask on this side of the table, just one email, one WhatsApp, and they said we will contribute. We can do anything for Pakistan if you want anything from our side. That is the level of development they have, the mental development as well. We here in Pakistan, we do not support our brothers and sisters. And they are willing to support Pakistan, जो कि पूरी दुनिया में मैं बोलूँ मैं कहूँगा पूरी दुनिया में हर एक मुकाबला कैसे रहते हैं, गालियाँ देते रहते हैं, हमें भी लोग जो है ना वो करने के लिए फोन उठाए, कभी कोई डिजास्टर हो तो सबसे पहले पहुँचते हैं, हमारी आर्मी पहुँचती है और ये बाहर से लोग पहुँचते हैं. So the thing is that in a system which is inefficient, in a system which is of poor quality, medical technology is the solution. And if I talk about genomics and genetics specifically, that is the future of medical technology. So people have done a lot of research where you can identify genes, you can identify not only identify genes, you can modify genes, you can replace genes. This is something which is a reality. And in Pakistan, where a lot of other marriages are happening, you know how much the burden of genetic disorders are. Every household has someone who has a problem. Every household. My own household and others, we have a lot of problems which are genetically transmitted, and they will keep on being transmitted if you want to have anything wrong. So genetics, research, and then finding some solutions for these genetic problems. Technology is there. We don't know what is there. So we should be, first of all, trying to improve our own knowledge and be proactive. Start this discussion today. We may not get all the solutions today. Maybe after today's discussion, we may have more questions in our mind, which is a very good thing. Actually, in Pakistan, we are always trying to get answers. We never explore the problem, we never explore the question itself. So even if we try to sort of expand our confusion and our, when we have to improve the understanding of something, we have to understand what is it, how deep the problem is. So if after today's discussion, all of these presentations, if some of us have more questions, the purpose is, that is the main purpose. We are so confident, so this is the mindset which we use normally. We give everything to the God and we don't do anything. So this is something which we have started. This is the first of its kind by HSA, but we will have the task will become larger after this. जो भी आज आए हैं, including Tyra, जो भी आज आए आपके बाद, the task will be higher. We may have a frequent 1 month, 2 month, or 3 month follow-up online. We can have a bigger conference with multiple different partners coming in. So आज की जो है ये एक roundtable discussion, you can call it sensitization about something which is there globally. There are very good presentations, very good topics. I hope the IT will support us. IT का बड़ा प्रभाव है जब भी whenever we have something online and something which is based on technology in Pakistan there are issues with a lot of bandwidth and other things. So I think as an academy we have a mandate for three things. One is capacity building and training. By the act of the parliament, we are authorized, we are actually being directed by the government of Pakistan to undertake capacity building in short forms, short courses and long courses like MS, MPhil and PhD. We have a one-day course as well as we have a 3-year PhD, a 4-year fellowship application committee. So there is a short, you can go to the website of HSA, you can find out what are the programs which we are running. Number 2 is research, conduct research in all fields of public health, which even it is written in my act, even animal sciences, because entomology and all these kind of things that the zoonotics coming to health. We can do research in animal sciences and agricultural sciences and all these kind of things, food security. So there is no limit to research for this organization as mandated by the Act of Parliament. The third thing which is very important and which has been missing in the past is the policy advice to the government. You know, the academia, the intellectuals, they just sit together and they don't share their thoughts into a policy brief, easy to digest language, and they don't provide it to the people who matter. And whenever they do, the language is so difficult that it cannot be understood by a politician or a bureaucrat. So the third mandate of Health Academy is to assist the governments, not just federal government, all the governments in Pakistan, provincial and regional as well. So we have to provide policy advice to the government, and which we have been doing for the last 1 year, a little bit of it. Part of planning commission working groups, part of ministry working groups, and part of a lot of other think tanks. We host the health policy think tank in Health Service Academy. It is a national level, international level partnership, and a lot of membership, diversified membership. We will be happy to contribute into some policy briefs and briefings to the media, briefings to the politicians, and briefings to the bureaucrats. These three pillars are very important for any decision making in the country. If you want to do something, these three matter the most: the politician, the lawmaker, the doer, the bureaucrat, and definitely the person who actually tells everybody what is going on, the media. These three will be our focus. Where in future we will have a targeted campaign of one session for the media only. We will invite all the media and journalists, leading health journalists in HSA to this room, and based on what we have today, after this discussion, this seminar is done, we will have something on the plate to tell the people, and we will have a lot of friends who will be presenting today. Hopefully, they will be able to come up and tell us more in the future. You all can contribute after listening to these talks. Hopefully, what we will do is we can have a separate session for HealthCare, and then we have a separate session, and we can go to the tips, parliamentary parliamentary tips. We can go there. All the politicians they come there, and the speaker is getting the podium of tips as well. So initially a sensitization seminar online. Most of the social media users repeat it, use it again and again. She shares it, if you reach the million, and then you can replicate it to other levels, and then follow up targeted to the people who matter, who can take decisions. That is the way forward. Hopefully, we have a very good intent in this. We have something which is our mandate, which is our duty. It would have been done years ago, but even today, I think if we are able to give the people a real sense of what genomics is, what genetics is, what research is, what medical technology is, and what AI specifically for. And you know, I am the focal person for non-communicable disease in Pakistan. Recently, we just did a lot of data registry analysis, data registries and data whatever is available in Pakistan, with various cardiac institutes, various tertiary care hospitals. It's a huge replication of, and it has become an epidemic. Non-communicable disease is now of epidemic proportion in Pakistan. 25 years, 26 years, people dying of stroke, getting heart attacks, CVA, so strange. बोले तो कभी यकीन नहीं करते कि ये बात है। इतनी आगे निकाल हो सकता है। वो कहते हैं कि हमें केस रिपोर्ट बना के। So we are doing something very wrong with our lives. That is why we are getting this chronic diseases, CVA, stroke, cancers, and diabetes at a very high percentage. 20% plus diabetes will be 1 in 4 Pakistanis adults is hypertensive. So our care की prevalence बहुत हो गई है। जो भी जा रहा है परिस्थिति में यही जगह एंजियोग्राफी कराता है तब डबल वैक्सीन there is a big epidemic of chronic diseases. Genetic disorder is already there because of consensual marriages. So I hope instead of don't cut the darkness like a candle. That is my approach. That was my approach. आपने अगर इस तरफ से भी आए हैं यहाँ पे आपको एक शेर लिखा हुआ नजर आया होगा कि शिकवाए ज़ुल्मत शब्द तो बेहतर था अपने हिस्से की क्षमा जलाते हैं तो औकारों में अपने हिस्से की क्षमा जलाएं यार आप मुझे कुछ लगे निकालते हैं तो अभी बुरा कहते हैं मैंने अभी किसी को बुरा नहीं कहा लेकिन मैंने खुद को बुरा कहा कि यार मैं 3 साल बाद 5 साल बाद कर I could have done this and I could have advocated for this if I was not in power to do something. I should have advocated the use of technology, genetics in Pakistan at least 5 years ago. We are at least 5 years late. I visited Singapore, South Korea, Taiwan, China 5 years ago, 2013, even 8 years ago. And they were using like anything. They were using these technologies every day. But itna to महंगा भी नहीं है शुरू में setup establishment cost is high, but then there is return on investment. Huge return on investment. Technology का जितना ROI है इतना किसी और चीज का नहीं है health. So hopefully we will be listening to a lot of good topics. If you see the topics, very interesting topics हैं. Heading पर भी इनकी आपको खुशी होती है. Try to get medicine out of it, and we will try के इसको हम repeatedly करें, regularly करें, और inform करके करें. It was sudden. We wanted to do it. Just कहते हैं ना कि सोचते रहे, सोची प्यार बंदा गया. मैंने कहा यार इसको कर लो, कैसा भी होता है. And then we can plan it better. So the first खतरा होता है बारिश का बहुत important होता है. और इंशाल्लाह चलते जाएंगे और कारवा बनता जाएगा. Thank you very much.
Thank you, Suzanne. Better late than never. And well begun and half done. Since it started, I think it's already on its way. And in a country where they spend so much on selecting the dress and the flowers and everything for marriage, it's high time that they know if their marriage is going to have a healthy outcome as well. And today here, we're not talking just about next generation genetics, but we're also going to talk about artificial intelligence, as well as newer imaging technology that's going to be very useful in all our remote areas, especially. And now I'd like to invite the woman behind it all as well. And I'm so happy that it's a beautiful woman, because women often get judged in this country, and a beautiful woman can contribute to the beauty of life. And like in the verses that we heard in the beginning, it was clearly mentioned that there are signs for you. It's all about how you read those signs and act. And if somebody is doing that and contributing towards humanity and health and alleviating the pain of parents as a whole, it's something exceptional. So I'd like to invite Dr. Vazna Khalid, Advisor, Health Government of Pakistan, to share her views.
That's a very kind introduction, and so I'd like to first of all congratulate my colleague, Dr. Shadad, and the talk is inspirational, always very hard act to follow. I'll be brief, and I think this is a very exciting initiative. I'm, in a way, the glass is always half full. We need to light the candle, as Dr. Shazad has alluded to, and do our efforts in terms of promoting preventive medicine, promoting also, in a way, to try and work out how we can strategize return on investments. I think Dr. Shazad alluded to in his talk how data and artificial intelligence and how healthcare can get essential remuneration and funding and money generation that we need so desperately for economy. And health is a huge economy. And we hope by doing this initiative and sowing the seed today that we're able to promote data, use of data, biobanks, randomized control trials, And our learned Chinese colleagues, and I'd like to thank them for their goodwill and their scientific diplomacy to come forward and help us, because it's the randomized controlled trials that will be generating out of this work, not just commercial genetic testing, but also the data that we generate from the randomized controlled trials that China is leading on. And in our neighboring country, India, randomized controlled trials in the pharmaceutical industry generate billions of dollars. So this is, as we have just said, it's never too late. This is a way of investment. This is a way of revenue generation, as well as this is a way to predict and tailor medicine, evidence-based medicine, data, genetic diseases, genome-wide association studies. We will be able to create a consolidated biobank for Pakistan to predict not only when we get married, which genetic diseases we are predestined to get, but also for the general public, if they want to understand if they are at a higher risk of developing diabetes, if they're at a higher risk of developing hypertension and stroke. There are tailor-made profiles of genes that you can predict which of those people are more predestined to develop those diseases. And this can be a public-private partnership, a commercial entity with the diagnostic laboratories sending their samples to help us to reference them and to give the data to the general public. I think I will end by saying that I wish Health Services Academy, DMC, for my colleagues here, my colleagues in China, and all around the world. But Pakistan is a gold mine for genetic research. We need to not only use it for academic purposes, to tailor-make our policy decisions to the government of Pakistan, but we also need to generate revenue in an era where economic adversity is really, the flavor of the money. I wish it all the very best. Thank you.
Thank you, Dr. Khazna. I wish Mr. Tariq had joined us today because he was talking about investment in the previous conference that I attended, and this was the best opportunity. We talk about building hospitals all the time, but prevention is better than cure, and coming to a solution like this is a real solution in India. Before we proceed, sir, मैं इनसे request करना चाहूंगी कि ये आपस में बातें और बार-बार दरवाजा मत खोलें. Distract होता है speaker और बहुत ही गलत impression जा रहा है आपकी international community को. यहाँ पे असल जरूरी बातचीत हो रही है. Kindly ये दरवाजा बार-बार मत खोलिए और आपस में बातें मत कीजिए. Please.
ने जो बात की मैं कुछ ऐसे कहूँगा कि हमारा इंटरनल लिंक है टेरिटोरियल जो एक हमारे यहाँ पे होती है मार्किंग की होती है हर बारे में और हमने जब ये किया मेरा अपना कल का एक्सपीरियंस है हमने ये शेयर किया इट वाज ओपन फॉर ऑल हमने किसी खास आपने देखा है कि बहुत बड़े सेरेमनी में नहीं हमने किया हमने कहा ये इंटेलेक्चुअल्स का और एकेडमिशियंस का और रिसर्चर्स का और मेडिकल टेक्नोलॉजिस्ट हो गया उनके लिए ये होगा इसको हम ऑनलाइन इसलिए रखा कि एनीवन कैन एक्सेस इट एंड देन रिकॉर्डिंग इसकी वही होगी रिकॉर्डेड वर्जन कैन बी फ्रॉम एक हमें एटीट्यूड अपना चेंज करना पड़ेगा ये जो हम कहते हैं ना कि मुझे सुबह से 50 फोन आ चुके हैं आप लोगों के लिए नहीं उन लोगों के लिए जो नहीं आए यदि हमें इंडिविजुअल बाय नेम पर्सनल इनवाइट नहीं किया गया पाकिस्तान जैसे मुल्क में जिसके अंदर इतने बुरे हालात हैं अगर कुछ अच्छा काम हो रहा है आपको पता चल गया अच्छा काम हो रहा है तो आप इधर नहीं करो तो आप आगे हमें मतलब आप ताने क्यों दे रहे हो कि आपने हमें नहीं बुलाया या ताने को नहीं बुलाया इट वाज एन ओपन एवरी पर्सन हु हैज कम टू दिस रूम इज अ वीआईपी ठीक है ना हमें ये जो वीआईपी कल्चर है ना उस मुल्क में जिसमें के 23% गरीब रहते हैं जो 2% की होती नहीं होती और हेल्थ एक्सेस आपको पता है 80% प्राइवेट सेक्टर में मिल रही है एजुकेशन प्राइवेट में मिल रही है 80% तो वो प्राइवेट सेक्टर में और पब्लिक सेक्टर में यही बात अवैध नहीं कि मुझे मिलती कि यार ऐसे लोग हैं जिन्होंने शिकवे कर निकाल बताया है सब कुछ बताया जो कमिटेड लोग होते हैं ना वो खुद पहुंचते हैं जिनको जिन्होंने कोई नेशनल कॉज जिनके जहन में होता है वो खुद कंट्रीब्यूट करते हैं तो आप सबसे ये रिक्वेस्ट है कि फ्यूचर में जहाँ की जरूरी है फाइन करें जाएं मिलें जो आप कर सकते हैं वो करें और मैं नेशनल अकेडमी किसी पर्सनल बंदे की ट्रेनिंग ये ओपन है इट्स अ पब्लिक प्लेस एनीवन कैन कम इन एनीवन कैन वॉक इन एंड दे कैन यूज ऑल द So ये थोड़ा सा हमें ना प्रोएक्टिव होना पड़ेगा और थोड़ा सा वो जो ईगो है ना वो कम करना पड़ेगा। मुझे समझ नहीं आती कि इसमें कोई हालात में इतनी बड़ी ईगो कैसे आ
इसके ऊपर भी जेनेटिक स्टडी करने की सब
इससे ज्यादा नीचे क्या जाए। मैं थोड़ा कहता हूँ मुझे एक पर्सन ये थोड़ा मेरा नाम नहीं याद आ रहा। We are all in the gutter. We are all in the gutter, but some of us are looking at the star. ये जो आज यहाँ बैठे हैं ना ये सारे के सारे स्टार की तरफ देख रहे हैं। इंशाल्लाह हम निकलेंगे।
Inshallah. I would like to request respected Lieutenant General Asif Mumtaz Sukaira. He's the Vice Chairman of Muhyiddin Islamic University and ex-Surgeon General to share his views.
Founder initial concept of the National University of Medical Sciences का नाम था, with an eye on medical technology and intelligence and a lot of AI based data, medical city जिसका कि अभी PC1 approve हुआ है. So he had a very big vision when he was serving Lieutenant General, he was serving Surgeon General of Pakistan, and he then was the founder, initial sort of person behind the Meta, जो कि टेक्नोलॉजी की और मुख्तलिफ आदमी को अप्लाई करती है टेक्नोलॉजी और लैब की सर्विस देती है, फार्मास्यूटिकल की सर्विस देती है. So very relevant for today, and also he has a lot of experience when it comes to medical technology, pharmaceuticals, and creating new institutes. Over to you,
Thank you very much. I'm honored to be here, part of this wonderful gathering of healthcare technology. Who are aspiring for it and who want to change this nation. After the detailed talk of Dr. Shahzad, I think there's hardly anything for me to say, because he's my teacher also in public. But just a few of my thoughts that I want to share that serving in Army for about 35 years and graduate of Confererece Medical College back in 1982. It was a long journey in the Army, serving in the field, in hospitals, and at the highest level in the general headquarters. We saw the healthcare system of Pakistan closely, and also happened to touch the healthcare system of developed countries like UK, USA, China. Went to China in 2017, twice, Beijing, Shanghai, and the liver transplant center, because we wanted to start the liver transplant program in the army. Basically, but I think that Pakistan, unfortunately, our healthcare system is primarily based on the healthcare curative model, and we hardly have any focus on prevention of disease. So whatever we achieve in developing the curative model, we fall short of resources because of the ever increasing and booming population. Just take the example of Rawalpindi, Islamabad. These cities were established about 50, 70 years back, especially Islamabad. And if we talk about Rawalpindi, across the railway line, half of the city doesn't have any public transport. It's only the cantonment general hospital. So that shows, that how things are working, and as I say that whatever we develop, whatever we achieve, falls short of resources and needs of public. So ultimately, we have to switch over to the preventive model, which was developed in a very good way in last about 25, 30 years back with the establishment of basic health units, primary health centers, rural health centers, and this is the city headquarters and district headquarters hospital. But somehow, with every passing year, that the efficiency and performance of that system has gone redundant. And we are now again back to the same place that this population of 220 million, they always go towards the tertiary care hospitals or even primary care or simple illnesses. So that is what we need to do. And if we talk about the reforms in healthcare technology, this is the first thing that we need to adopt: how to prevent the diseases. Second thing is that the private sector, of course, once the public sector doesn't perform, the private sector comes in. But the private sector comes basically to make money. And that is the reason that this huge population of Pakistan is spending a lot. And every year, because of the healthcare challenges, about 15 to 20% population goes below the poverty line because of the healthcare disaster. एक गरीब आदमी है, उसके घर में उसकी बीवी का प्रॉब्लम है, सिजेरियन होता है, he has to sell his cow or his buffalo. That is the earning hand in the house. So that is the challenge that we are facing today. What we need to do is to blend the tertiary care or the curative model, the preventive model, and the technology together to move forward. And then in Pakistan, we have multiple healthcare stakeholders. As Dr. Shahzad has mentioned, that we try to work in our own silos. In the army, I know that we have about 45 military hospitals, about 40 field hospitals, and they are spread in the length and breadth of country from Siachen down to Gwadar and from Chaman to Lahore. A lot of civilians, they get treatment from the military hospital, and I can assure you that they get the best possible treatment available in the world in these military hospitals. But then the civilians come here for treatment after payment of nominal charges. So what I want to say is that we need to work together, the army, the civil side, and the private sector, to address the healthcare needs of this country. And for that, we need to work on the curative model as well as on the preventive model. Why I'm saying this? Because the data of the army, whatever disease burden we carry, is hardly shared on the civil side. Dr. Shahzad said that whenever we talk about the data, we always quote the data from other countries, and we don't quote the data what is available in Pakistan. That is because of the reason that it is not publicized. Somehow, that role has to be taken up by the government and the media. But unfortunately, media, with about 70, 80 news channels, and put all the prime time of this nation is taken only in politics, and we are developing future politicians, and we are not developing future, IT professionals, doctors, and educationists to take this country towards progress. We have the best brains in the country, and there's no doubt about that. The doctors in Pakistan, they are the most sought after in North America and UK and other places. We have the best dentists, we have the best nurses that we produce, because that I can say because in the army, the surgeon and then deputy surgeon, UK Royal Defence Medical Services used to send their delegation about 15-20 doctors and nurses and specialists every year to work in our hospital, to train our doctors and also learn with our experience. And they used to say that I always requested them that I want my nurses to get exposure in UK and Europe. But they said you don't need that. You have the best possible nurses. You just need to train them in some of the technology, and that what we can support. So I can say with a lot of pride that I established contacts in UK, especially in Staffordshire and Midlands and Keele University, and that is now giving dividend because our doctors, our GPs and specialists are getting trained there, and we are also contributing towards their database and their research. So finally, I would say that to develop the healthcare for the future, what we need is to make use of information technology, artificial intelligence, biotechnology, pharmaceuticals, genomics. These are some of the fields that we need to group together and work together for prevention of the diseases. One of the success stories that I want to share is that in Army, of course, we have a huge population planted that we look after, and especially the families of the soldiers. The incidence of breast cancer. This is prevalent, and every year from the President of Pakistan, from his house and from his office, this campaign of prevention of breast cancer is generated. And Dr. Shahzad has been a strong partner in that. In the Army, what was happening is that I visited one of the biggest hospitals, the military hospital in Rawalpindi, and there I saw, once I went to the diagnostic center, we have latest, MRI, CT scan, Dopplers and ultrasound and X-rays and everything. And we also have the latest mammography. So I asked that what is the, numbers of, women reporting from mammography. And it was to my surprise that in a month, hardly 2 or 3 patients now. So that shows, that how much we are serious in breast cancer screening, how much is the awareness in that. So the success story that I want to mention was that we got a civilian doctor, Dr. Radia, in MH Rawalpindi, CMH Rawalpindi. She applied because she had an exposure and training in breast surgery. So we brought her as a civilian consultant under a special case ethics. And I tasked her that you need to establish a breast clinic, and that should be sort of a one-stop clinic and treatment center and advice for all the ladies that walk. Because what happens in our society is that in any home, a lady or a girl who develops something in the breast, she's shy to share with anybody, even the female members of her own home. And what happens that once it aggravates, then maybe after a month or 2 months, she shares with her mother or sister or her in-law. And then they say that, okay, they try their local, remedies, whatever they have learned from their seniors. But that doesn't work, and they think that, okay, let's go to some lady doctor. And they go to a GP, and then they go to a lady surgeon or a gynecologist, and everybody says that this is not our domain, this is the domain of the surgical specialist for the breast surgeon. And in Pakistan, we hardly have few, not even double-digit breast surgeons. So that is what we did in CMH Rawalpindi, that any lady coming with a complaint of any problem in the breast, they used to walk into that clinic, and they used to be facilitated in all their tests. You get this check, go to the radiology department, get this check and get your test done in the pathology lab. Everything was facilitated by that single clinic. And finally, the decision about the surgery, about chemotherapy. And then the second step started, and that was giving awareness to the people that we need to report early for any breast cancer, because that is the key in curative surgery for the breast cancer. So, and then the third step started, and that was the screening of the ladies of that family, and in that we have been working. I visited Leeds Hospital, teaching hospital in UK, back in 2017, and there we have a Pakistani nurse. She is working there in the genomics department, and we developed a link with them that they were basically working on mostly the research was on people of subcontinent because of consanguineous marriages and the diseases that come out because of that. So I would like to link them with Dr. Shehzad again, because Dr. Shehzad, since the time he has come and taken over this health service academy as the head, for the last few months he has turned around, and we see a lot of activities and so many things he has brought on his plate, that I only pray that Allah gives him more energy to take this project forward. And ultimately, finally, I will conclude by saying that we have been working, our generation has been working to put the things right, to take Pakistan to further progress levels. We succeeded in some fields, but we got defeated in many fields. So the future now lies with the new generation. And the new generation are the young doctors coming out of which about 70% are female. Most of the male doctors, after graduation, they try to go to USA, to UK for their advanced studies, and then they never come back. The female, because the family compulsions hardly, 50% work, but those who are work most of them they work in Pakistan. So I think that is what we need to do to empower the female, approach them, and facilitate them in contribution towards the healthcare system of Pakistan. And I'm happy to see Dr. Ladna here, and she's leading and one of the, top partners in this conference also. So my prayers for this success of this workshop and this conference for the next today or tomorrow. And as Dr. Shahzad mentioned that we need not to go for any invitation. So मेरी कोई आना है. He just talked to me last night that are you available tomorrow? I said even if I am not available, I will be coming. Because this is something that we need to continue together. Allah has gifted us, with so much of respect, honor by, taking us high in the ladder of healthcare system in Pakistan. So this is time for us to contribute back. So this is my message to all the participants that please come forward. इसका गिलाना करें कि ये काम हुकूमत का था, ये फलां का काम था, ये फलां इदारे का काम था. हमने मिलकर इसके लिए काम करना है और हमने इसको आगे बढ़ाना है. I am father of two daughters. One of them is a doctor, she is a pulmonologist, and the other one is a dentist. So I know that I have been supporting them all along, and that is the success because of their disposition. That I say that I'll take care of all your needs because whether your kids or your family, but you have to contribute towards the healthcare system of this country. So I'm thankful to the Chinese delegation, our brothers, because I believe that they are always forthcoming in helping us. And any nation, I would say that, as Dr. Shahzad has said, to name, and people are here ready to come there to contribute, and that is because of the huge population that we have of 220 million. If you name any disease in the world that is prevalent over there. And lastly, I would say that please build strong connections with the army also, because luckily we have the surgeon who is a public health specialist. And we have a strong presence in Africa because of the UN peacekeeping missions. I was there in 2005 and Lassa fever was prevalent over there. It is a viral hemorrhagic fever. We got the training for that. And then later on, the Ebola pandemic and then malaria falciparum and so on, so many diseases. So through the army, we can also contribute through our contingents in place in Africa to have the health intelligence and prevent our future contingents from any such exposure or disease to keep the safety of our individual and our human resource, a very valuable human resource. Thank you very much. And
thank you, General Sir. Thank you. I hope we can benefit from the system, discipline, punctuality, and accountability of the army in our circles as well. I'd like to now request Ms. Navmana Hashmi, ex-ambassador to China, to share her views.
Friends who are joining us online. A lot has already been said, and so because of the paucity of time and the sake of avoiding any repetition, I just want to say, first of all, there are Chinese colleagues and friends sitting here. There is a lot of talk about following the Chinese model of development. And what I would like to tell all my friends here is at the heart of the Chinese model of development are three things, which enabled China basically to become another superpower in the world now. And that is all focused on the people, on the individual citizen of the country. And the philosophy is that if you have a healthy, educated, and happy citizen, he will be more productive or she will be more productive and will develop, contribute to the development. Now, the public health system of China is the most comprehensive and the largest public health system in the world. And they have ensured healthcare to all their citizens. And they are much more than us. They are almost 1.5 billion now. And it is this healthy population that you see taking China to the stars. The second important thing, and in the healthcare, they particularly focus on the healthcare of women and children. And because these are healthy women and educated women, because it was healthcare, education, and the third was making the women an equal partner in the work. So if you have a healthy population, if you have educated women, and they contribute to the economy, then you see the miracles that China has been able to deliver to the world. They took 800 million people out of poverty in a short span of 15 years. I have had a long interaction with my Chinese friends, but I got to see them twice. So my experience of living and following China spans over good 1 decade. So today I am very happy to see that this first window of opportunity, or the first step that we are taking towards diagnostic in processes in genetics is also in consultation and in cooperation with our Chinese counterparts. They have, whether it is their doctors or nurses or the use of technology, the Chinese are leading. Western countries have very good diagnostics. Also, we are cooperating with the Chinese medical company for bringing this diagnostics and for training. I would like to, my message would be, like Dr. Sazad also said, that we don't have to wait for others to come and do it. We need to establish this health corridor and go and seek what we need and not be shy. So let's start with the Chinese friends, let's start with the German friends, because we have a lot of German technology and medical potential, and a lot of other European and American technologies also have. But let us today, like the Chinese, make a fundamental principled decision that if we need to progress, if we need to develop, then we have to have a healthy population, a happy population, and an educated population, and that's the only way to development is there. So I wish Dr. Vasna and Dynamics all the success in this initiative. And we who have, there are other colleagues also who have served all over the world. And if we can be of any assistance in making those connections, in helping you totally on voluntary basis, we would be more than happy to help, because it's not about us, as some also said, we have lived our lives. We have achieved what we have to achieve. And it is all because of Pakistan. It is now time to give back to the country. So we would be very willing to help in any way possible to ensure that not only this project, but any other project that is for the benefit of the people of Pakistan, we will.
Thank you, Ms. Nahmana. Thank you very much. Healthy, happy, educated. Those were the key words. And let us move towards a short tea break before we proceed to our sessions. All right. So we move to the next session then. और सेशन साथ साथ करें सेशंस में ही शुरू करें राइट अभी
My colleague from China wants to.
You want the Chinese ambassador?
Whatever, but take him because he is a partner there.
All right, so let us move ahead to the session with the Chinese ambassador first. Can I first a quick visit to Air Doc as well as Dynamic Medical Group?
My job is to make college easier because students have a lot. My job is to make college easier because students have a lot.
see a child, looks like a 10-year child, and the death of the child happens at the age of 10 to 15. I've also worked on another monogenic disorder in my second postdoc, and that was pneumonia, and there the gene involved is memory. It's a muscular disorder, and it's a hereditary disorder. That means the appearance are just normal, and it just happens that there is a certain mutation. The mutation of 184 cytosine is linked to timing, and then all of a sudden the symptoms start appearing. There are also chromosomal aberrations. What happens there is that all of a sudden there are some alterations in the number of chromosomes. As we know that we have around 7 trillion cells, and in each cell we have nucleus, and each nucleus has a normal human being has 46 chromosomes, 23 pairs, 23 come from the father and 23 come from the mother. There are some disorders where we have abnormal chromosomes, and those are called autosomal disorders. And there, as I said, normal number of chromosomes is 46. We can have more than 46, we can have less than 46, or we can have, there is double XY, there is triple XY, or there can be an additional Y and extra X. I think, when I had my kids in Finland, my wife went through this test in Finland. And if you go to a test and you are told at a very early time in the pregnancy that, you can have this Down syndrome or you don't have the Down syndrome, then you can continue with the pregnancy. If you have read the concept note, in the concept note, it's also written that what happens. Why do we want to go for the genetic testing, and why we are speaking about genetic screening and sequencing? I think everyone has heard about thalassemia in Pakistan. It's quite much prevalent. If I just speak to everyone here as an audience, if the couples can go to a test before the marriage, which is a condition in many countries, and for example, if a woman is carrier of thalassemia, and it is found out that she can carry, you can then stop that marriage. If you do not get married, then you do not have those kids, which have the male kids have a chance of, if he gets that X carrier from the mom, 100% probability of getting the thalassemia. And the woman or the girls of that mother can still carry the same gene onwards. So just by having genetic testing and screening before marriage, you can avoid those kind of risks. There are other examples of these syndromes. I can just skip all this. Maybe conclude that it is very important that today we have DMC and we have the Chinese partners. As Alresta was saying, that it is very important that with the China-Pakistan economic corridor, we can also, we already have initiated China-Pakistan HealthCare corridor, and I think it's a great start. We are planning big things for Pakistan. We do not have, there are a lot of gaps. There is no basic research, there is no applied research, and all these different genetic disorders that I was saying, by having these high-tech testing, screening, genetic counseling, genetic counseling here in Pakistan, you can start those facilities, you can significantly reduce the disease burden. Thank you very much.
Thank you, Dr. Mubashir. You all heard it. Thalassemia, you've seen muscular dystrophy, hemophilia, all is extremely rampant. Prenatal screening, and after prenatal screening, I'd like if somebody could actually even talk about what are the laws governing the decision to terminate the pregnancy if one finds it out. Before moving to the next session would be on artificial intelligence solutions in chronic diseases by Mr. Ryan and Mr. Richard of Air of China. You've seen their stall here. I'd like to request them to go ahead with their session. Leading Air Technology Co. Limited provides artificial intelligence medical solutions, and it offers medical image analysis, health data analytics, and other services. It has also signed an MOU with Dynamic Medical Company and is working as a developing partner. Is Mr. Richard and Mr. Ryan here, or will they be delivering it? Mr. Richard and Mr. Ryan, it's your turn to deliver your session now. Artificial intelligence solutions and in chronic diseases. Yes, please.
Who's taking care of the IT here?
You can come here then. This is like. Thank you. Maybe this.
Okay, thank you all. My name is Ryan from AirDoc. My topic is artificial intelligence solution in chronic disease diagnostics. Okay, here first show some data is challenging to the global health. Here is some major chronic disease that threaten to the health. First is diabetes, is the numbers is increasing very fast. Second is heart disease and stroke. Third one is the hypertension. Chronic are increasing rapidly, and the trend seems losing control. So this is chronic disease treatment is also big burden to the economics. So according to the data of the WHO, the chronic disease account for 73% of the all global deaths and 60% of the global death burden. So it spends a lot of money to control and treatment for the chronic disease. This is the one graph from the IDF, the Atlas, the latest world intense world, related to the diabetes. Diabetes is right now the major chronic disease that is related to more than 100 of complications. So out of the world speed increase speed is 46%. In some countries controlled well, some countries controlled backward. So this is the complication of the diabetes, and a lot of disease is related to it. And the diabetes patient has type 1, type 2, and others. Type 2 is occupied 80% of the patients. That can be prevented and controlled. This is something related to the eye disease. Is from the World Report on Brain is read on the WHO. And you can check the diabetes DR is occupied a large number as well. So this is the worldwide problem out of the world shortage of ophthalmologists. And some health facts for Pakistan here. There's normally like here right now we have a number of 5 top common chronic diseases here. First one is right, second diabetes and lung others. For this, the diabetes for here, top third one. The number one in China, second is India, third one in Pakistan. You can check the diabetes patient the number. Right now it's roughly around like 33 million. Even for that, many people they don't know they have diabetes. Nearly half of the people never check they have diabetes or not. And here's some, the average per million people for the ophthalmologist. We have roughly like 11. If you cannot remember this number, you can see this. One ophthalmologist, you have to many people. If provide that ophthalmologist working every day in here, and he has to check in every day for 249 patients, means per day, means non-stop, all day working. So this is the shortage of the ophthalmologist. So how to do? Artificial intelligence solution in chronic disease diagnostic. It can for the disease. Earlier screening of the disease is a great significance to the people and the country and imaging examination. The important part of the screening disease. Artificial intelligence can help to improve the work efficiency of the diagnostic and medicines. Instead of to maybe to have a doctor, you have to need to 10 years maybe for the ophthalmologist to be reading the retinal images. So next is we are Aerodot. We are an artificial intelligence medical company. We develop AI health assessment software quickly and accurately analyzing the chronic disease using the retinal images. This is our company R&D capability world class. First one, we have powerful AI deep learning algorithms. Now it's more than 50 algorithms are already done. And the second is we have the largest database for the retinal images. Third one is the high efficiency and virtual AI in neural and structure. Next is we very strong R&D teams, and we have very powerful eye hospitals in China and other organizations working with us. And we also publish a lot of papers on the Lancet and Nature different academic journals. This is how our AI is working. This is the working chart. And the final result also can be reviewed by the doctor. Means finally the doctor can sign on the document. So the AI is a good assistant to the ophthalmologist. This is the type of feature of our AI. High accuracy. When we train the algorithms, compared with the expert for the eye hospital that 1 year he can reading 20,000 of retinal images, and for whole life roughly like 600,000 people. But for our AI already learned is too much. Means the accuracy is 760 years experience. Second is convenient. Only through the retinal images can be that 50 diseases or lesions in 6 categories or 9 categories. The last one is very fast. From get the retinal images and generate the report only takes 3 minutes. So this is what we have solutions. Our AI is working with the most famous brands of front camera. All is working. Second, we have our automatic portable front camera. It can be supported by the power bank and it can be put in the bag and to take anywhere for the eye checkup. Maybe something why from the retina we can detect the chronic disease. This retina is the only part of the human body where blood white cell and nerve can be directly viewed in a non-invasive version. Means no need to take in blood or other things, only take a photo of the images. It can get many things from these images. And this is the new technology, but already used many years. 1925, Carl Zeiss invented the first funded camera to observe the retina. After using that, many diseases, major in the ocular disease and systematic disease, is something like plaster or other things, is many. This is some idea about the retinal images. The first one, healthy one, another is with some problem abnormals, and some is blood leaking, another is for the DR, is diabetic retinopathy. Last one is the brain tumor. So this is the vision. When the people had the eye disease, the first one is glaucoma, is a tube brain. Second is something like that. Another is for the DR. Last one is for the in that time. So this is the way training the algorithm by using the images, double blind labeled by 300 of mortgages from worldwide. More than 10 million retinal images have been run by the AI algorithms. So here is I don't know. Yeah, you can play. No. Yeah. This is how the AI it works. This is the retinal images, and it can be through the algorithm. It can multi analyzing. For our AI, like more than 50 algorithms running the same retinal images, and it can be done the multi in one time. Okay, next. So this is the what we already have for the 50 disease or disease in 9 categories. Is related to the vascular, tumor-related, DR, macular, myopia, spectral glaucoma, optic nerve, and others. So this is the diseases we can diagnose. We have published a lot of papers and on the academy and journals from last 7 years already. We have more than 200 patents for that, and 100 more is under processing. Here is the airdrop doing. This is the largest real-world study. It is 260,000 people involved, and 14 diseases involved, and the accuracy for this study is around like 95 to 98% the accuracy. And we published the paper on the Lancet Digital Health. And this is another study for VCD, it's cardiovascular disease. This model, it is work for predict the disease potential risk means for next 10 years. It is different from traditional method. You have to take the blood and study it and for the testing. But for this, only using the retinal images, it can be finished. It's made by the Peking University Clinical Research, and we published the paper on the Science Bulletin. So it's another. So this is the another is for the AI how where it used. This is right now we already done the commercialized in China and other countries. In China, we do more like in the clinical department for the hospitals, eye hospitals, and some hospital with the department for the diabetes and for the physical checkups or examination centers. And another for can use for the community clinics, and another is for the. Thank you. For we can use the AI for the optical stores and the insurance companies, not for the pharmaceutical companies. It can giving the like a promotion grants for them and generate more testing for the people and get who is may need the medicines or treatment from the hospital. Okay, that's all.
Thank you, sir.
Thank you.
Thank you.
Thank you very much. I'd like to request all of you to keep it short and brief and not exceed 5 minutes, please. The next session is Bringing Clinical Value Through Validated Analysis by Dr. Thomas Borge of Norway. Bringing Clinical Value Through Validated Analysis by Dr. Thomas Borge, Norway.
Yeah, hi. I think I found the mute button there. So can you hear me?
We can hear you, but we can't see you.
Okay, can you see my slides?
Yes, we can see your slides.
Okay, good. That's the most important. So thank you so much for inviting me to this meeting. I'm happy to talk about how validation of analysis brings clinical value to patients in the end. And I added transparency as well to my title because that's part of the validation, not only validating but also showing the validation. So I'm working for Blueprint Genetics, which is a diagnostics company, and it was founded by clinicians 10 years ago, basically to bring DNA out to other clinicians so they could take advantage of the NGS technology. And we've done that very successfully for 10 years. And let's see here. 2 years ago, Blueprint were acquired by Quest Diagnostics, which is a huge US laboratory, a Fortune 500 company. And they will definitely help us bringing this out to more clinicians, more hospitals around the world. And it's been already talked about, you know, how much rare diseases there are out there. So each one of them might be rare, but together it's a substantial amount of patients out there that is in need of getting a precise diagnosis. And it's a lot of doctors out there seeing these patients and that are trying to find the best option for their patients. So what we're doing is searching for a needle in the haystack, and not only a needle in the haystack, but the right needle in the haystack. And the rare disorders has traditionally been a long and complicated journey from the symptoms from the patients to getting the accurate diagnostics. But with the technology today, that path can be done in quite a short time if you have the right tools. But what is the right tools? When a doctor is standing there with his patients, there is a lot of options today. You have a lot of different labs doing genetic diagnostics. They can do whole genome sequencing, whole exome sequencing, panel sequencing, single genes, or testing for specific variants. And it's not always easy to find the right lab and the right tool. All the labs are saying they have the highest quality and the lowest prices. And going to the websites, it's not always easy to see what they actually have. I will strike a blow today about gene panel approaches. This is still the golden standard of genomic medicine. And this slide is a busy slide, and I could probably talk a lot about this topic, gene panel versus whole exome sequencing and whole genome sequencing. I don't have time for that today. What this slide basically say is that if you have a good high quality gene panel, most patients today will benefit from that rather than any other genomic approach. I've seen, this paper on the right here saying that as a first approach, any other standard first molecular diagnostic test gives as high diagnostic yield as a whole genome sequencing test. I don't say that whole exome or whole genome is not a good idea for the patients, but it's only a selection of patients. It's the complicated cases or the ones that have been tested with different approaches earlier that should be tested with these comprehensive approaches. And genetic diagnostics is not like straightforward, easy. I mean, even today with all the technology, as much as 1 in 7 pathogenic variants can be challenging to detect. So if you don't have the right tools, these are really difficult to find. And this is also what makes a big difference between different labs, and a very good reason to be very transparent about the technology and what is being done. So how can we improve the NGS diagnostics? And keep in mind that I'm talking about gene panel sequencing here. So we could do clinical R&D, lab R&D, and also R&D in the bioinformatics side, and especially maybe in the bioinformatics side is where a lot of things are happening today. And by this development, ability to detect copy number variants, non-coding variants, and difficult to sequence regions, as well as other parts of the DNA, like the mitochondrial genome, is improving. A standard way of evaluating the performance of genetic testing is talking about the coverage. And for gene panels, we're talking about if the panel covers the relevant genes, and are all the coding regions covered in the genes. How about the hard to sequence regions? And is it enough coverage to call the copy number variants? Do the analysis include the exon intron boundaries, and to what degree? How far into the introns are you sequencing? And do you add the non-coding variants to the platform? And also, are the mitochondrial genome covered? And if you do that, it's really important to actually show how good you're doing it, and not just say that this is covered, but you can put a number on how well you're doing this. And this is really important to demonstrate this performance, and with different mutation types as well, and different sample types. So by doing this, you can establish a standard for your quality, and together with these standards, you really describe the laboratory's philosophy to run the diagnostics. And it's also a standard for your own laboratory to develop and improve, and also for other labs to measure up against that.
Dr. Thomas, may I request you to keep it short, please, because we have 10 minutes per speaker and we have a lot of speakers waiting.
Yes, I will. So I still have like 6 minutes, I think. I will show quickly now on our website how we are showing quality and how we are transparent. So this is the blueprintgenetics.com, and under diagnostic tests you find everything we do. So we do whole exome sequencing, single gene tests, and all these panels. So by clicking into one of the medical fields like ophthalmology, you see the different ophthalmology panels we have here. One of them is the retinal dystrophy panel, which is one of the more comprehensive panels. Let's see if it's open. Try to click again. It's a 351 gene panel, and as we see on the panel side here, it includes non-coding variants. It also includes the inherited mitochondrial genome, and it tells what kind of patients this panel is ideal for. It also says which genes are not covered, and that's also part of transparency. Under here, you can see the panel content. Genes that is not covered like 100% are highlighted, and you can click on that to find an explanation on why this gene is somewhat problematic to sequence. And
all right,
for all
Dr.
gene
Thomas,
panels,
I'm afraid we'll have to come to an end because our other speakers are aligned for 12. So thank you so much for your detailed discussion, and definitely a more detailed discussion awaits for next time. Thank you, Dr. Thomas. We'll move on.
Okay,
to
I
the
only
next
got 10 minutes
now.
there.
Can we move on to the next session? Yes, so the next session would be Gene Technology by Ms. Christina and Mr. Han, BGI Genomics. And I would like to please request them to keep it short. Each speaker has 10 minutes, so their time starts at 12. Please, by 12:10, you need to end the session. So Ms. Christina and Mr. Han. Can you listen to us, Ms. Christina and Mr. Han of BGI Genomics? Please unmute yourself, Ms. Christina, so that we can also hear and see you. If you would have to switch on your camera and your audio and switch it to unmute, please. Gene Technology by Ms. Christina and Mr. Han. Can you hear us now? Can you please unmute yourself and raise the volume of your system? We cannot hear you. Apparently everything is okay from our side. Can you please check your system and see if it's on unmute? Because we cannot see you nor hear you. Miss Christina and Mr. Han. You are still mute. Can you please unmute yourself? It is visible here that your setting is on mute. Can you unmute yourself, please? We still can't hear you. Can you? Maybe we should move to the next session and then come back to them. We can't hear you. Can Miss Christina hear us? Okay, let us go to the next session. Let's move to pharmacogenetics by precision medicine and clinical sciences. Dr. Jari Thorstone from Finland. Let's move to him, and then when Ms. Christina has it sorted out, we can move back to her. So now it's session 5. Pharmacogenetics and precision medicine clinical science by Dr. Jari Thorstone of Finland. Dr. Jari, I would like to request you to please keep it short as well. Your time starts at 12, so by 12:10, kindly wind it up. Can you hear us?
Okay. Can you hear me?
Yes, we can hear you.
Okay, thank you. Good morning to everybody, and greetings from Finland, from Europe. I'm a specialist in internal medicine, and I will shortly describe the field of pharmacogenetics and how we do the pharmacogenetics diagnostics in clinical work in Finland and Europe. As you may well know, the same dose doesn't work for everybody. Some get very serious adverse reactions, and for some, the same dose may not work at all. And it's very much related to pharmacogenetics, because the metabolism.
Can you please raise your volume a bit? We cannot hear you. It's very, very low.
Yeah. Can you hear me now?
Slightly better, yes.
Yeah. The pharmacogenomics is often behind these differences in the drug effects, and due to differences in drug metabolism, the levels in serum can be very different. And with normal drug instructions, if you have normal pharmacogenic enzyme function, the standard dose will work. But if you have, for example, very slow metabolism, you need to have a lower dose, perhaps half of the dose. Or if you are so-called ultra-rapid metabolizer, you need a higher dose, perhaps double or even 3 times the normal dose to get a pharmaceutical effect. And in some cases, due to genetic reasons, the risk of adverse reaction is so high that you have to change totally to another drug. Pharmacogenomics is defined as a field of pharmacology which studies the effects of hereditary factors in the metabolism and effects of drugs in patients. And I encountered a doctor who said that he had asked if the patient has any allergies, and the patient says, no, I'm not an allergic, but I'm CYP2D6 metabolizer. And the clinician didn't know about that, but it was very clever answer from the patient, because this is a similar kind of individual factor that should be taken into account when we prescribe the drugs to patients. Based on CPIC recommendations, CPIC is an international authority in pharmacogenetics. The metabolism is often divided in different groups. Normal metabolizer means that the normal drug dosing instructions should work quite well. But if the patient is ultra-rapid metabolizer, he may require larger dose, and for poor metabolizers, lower dose. And this terminology is standardized or harmonized through CPIC. And it is currently used also in drug instructions. This is one quite a new psychiatric drug, Rexulti, brexpiprazole, and there in the dosing instructions, it's clearly said that if the patient is known to be CYP2D6 poor metabolizer, administer half of the recommended dose. And it means that the drug cannot be used properly without knowing the pharmacogenomic test result. And that has led to a situation where in a very big share of psychiatric patients, we already test this pharmacogenomic panel. In Finland, we have now different panels, but normally it's about 20 genes. In psychiatry, these CYP enzymes are the most important ones. CYP2D6 is the most important gene in pharmacogenetics in general because over 50 different drugs metabolizes through CYP2D6 so that it has effect on the dosing. I don't go into details of this gene list. This is one example of codeine metabolism that just shows how important the CYP2D6 role is in the metabolism. Codeine is not a good painkiller. It is, the function comes from morphine. It has to be changed to morphine through CYP2D6. And if the patient is slow metabolizer, the CYP2D6 is not working and the patient cannot produce morphine from codeine, and that's why codeine is not working as a painkiller for those patients. There are about 5% in European population where the codeine doesn't work. A more dangerous thing is that the CYP2D6 is ultra rapid, so the patient produces much more morphine from the codeine than the standard dose should estimate, and that's then causes a morphine intoxication that may be even lethal. This is a good picture from psychiatric drugs and the effect of CYP2D6 enzymes in the metabolism of these drugs. On the y-axis, you see the pharmacogenetic difference in drug clearance between these different metabolic groups. And for example, this imipramine, noxepine, nortriptyline on the left-hand side, there may be almost tenfold difference in the drug clearance between the poor metabolizer and ultra-rapid metabolizers. And so everybody can understand the same dose cannot work for those patients. And that's why the dosing should be adjusted according to patient's result. This shows one example of escitalopram, very widely used antidepressant. If you have the same dose, 10 milligrams or then 20 milligrams daily for the patients that they are in different metabolism groups, you see that in ultra-rapid metabolizers, the serum level is very low. It's under the treatment target, but in poor metabolizers, it goes much above the level of 40 that is normally the aimed level. So with the same dose, some patients don't get any effect, and for some patients, they have serious adverse reactions. But if we have done the CYP2C19 testing, and we can adjust the dosing based on this CYP2C19 metabolism, then we can get every patient to the treatment window and they get better effect without less adverse reactions. And this is in theory, and then in practice, when we have, this is quite a good study in the treatment of depression. Without gene testing, only 9% gets remission within 4 weeks and 13% within 12 weeks. But if we have this gene test guided treatment, so the dosing is adjusted according to the gene test, we can get much better treatment results. Also, cost savings are quite remarkable in mental hospital in the States. They studied the total cost difference. It's almost half the cost of the patient's treatment if we have personalized dosing in psychiatry. You can find these in the PubMed, these publications. Then about the frequency of these different metabolism types, they are in Finland, but these are very similar throughout Europe. and many of these are valid in all countries in the world. But remarkable here is that, for example, CYP2C19, only 40% are normal metabolizers. So over half of the patients need to be adjusted dosing for their citalopram treatment, for example. And for CYP2D6, 2/3 are normal, but then very many are intermediate metabolizers, meaning that they are a little bit slower and they require less medication than the normal dosing.
All right, thank you, Dr. Yari. We are short on time. Thank you very much for sharing your valuable views with us. And let us move to the next session now. Thank you. I appreciate your presence. Thank you. So moving on to the next session by Mr. Bilal Mumtaz, co-founder of
BGI. I requested the CEO of BGI.
Ms. Christina? Mr. Han. All right.
Together supporting like this. Just a quick 1 minute line on the BGI. BGI is a very strategic development partner for Ghana. After the COVID breakdown, this is the first company who has the SQC and NDMA in Pakistan for the initial PCR testing kit. They have provided 100,000 kits on a GDP basis to the government of Pakistan, and their kits made the solution of bringing it. So BGI now have a plan, a strategic plan investing into Pakistan, and they are collaborating with HSA and NIH in developing, inshallah, the first next generation technology lab over here. So I requested that they had, although it's traveling very strategic, two-sided, but I agree with an online. So that they had over to you under our great style advice, please.
Thank you, Mr. Han. You will be giving the session on gene technology. Can you hear us?
Yes, I do. Hi.
Thank you.
So I will share my screen. So, hello, can you hear me?
Yes, we can. Thank you.
Yeah, please allow me to share my screen.
I think I can here help it if you just share them. The operator here can assist on this.
Hello, can you see my screen now?
Yes, we can.
Okay, so let me make it the biggest. So yeah, it's my pleasure to do a BGI brief introduction to all of the audience here. And I am Xiaohan Wang. I'm currently the general manager for BGI on East Asia, Southeast Asia, and South Asia. So today my introduction will be separated into 5 parts, which is the organization, our products and services, and research and development, and also our COVID-19 response, including the social responsibilities. That's one. So first of all, BGI, we are founded in 1999 because of the 3 most ambitious program in 20th century. The one is Apollo Moon Project, and also the nuclear bomb project, and also the Human Genome Project. So BGI was responsible for 1% of the Human Genome Project. Now, after years of development, BGI now have around 10,000 employees, and our product services has been available more than 100 countries in our headquarters in Shenzhen. We also published more than 3,400 SCI publications, and 400 plus of them are published in the world leading journals like Nature, Science, Cell, and New England Journals of Medicine. And we also granted more than 1,200 patents. Our mission is to be a world leader in the age of life science. and our value is to deciphering the secrets of life, boosting the growth of the life science industry, and working for the betterment of the mankind. So next, our in BGI Group, we have 9 different subsidiaries. The above 4 are non-for-profit, which are BGI Research and BGI College and the China National Gene Bank. It's invested and built by the Chinese government, but BGI is entrusted to be operating things the first day. So we also have our own scientific journal, Giga Science. Its impact factor now is 7.267, which ranked number 6 globally. And the lower 5 are our profit entity. The first one, the red one, is where I am from. The BGI Genomics now is a listed company in Shenzhen stock market. And BGI Genomics emphasize on providing services and solutions and also focusing on big data. And MGI is the responsible for manufacturing our self-developed sequencers and also automation systems. We also have BGI Agro working on the molecular breeding by utilizing NGS technology. And we also have BGI Health, mainly focusing on our employees' health management and try to create a first world largest longevity platform. So also BGI Medicine is now building the first future hospital with the Shenzhen municipal government. So next, BGI Genomics, our core business is to provide the genomic testing and research services to healthcare providers and research organizations. The hospital and our target customer are hospitals, consumers, laboratories, universities, colleges, and also the research institutes and pharmaceutical companies. And our services have been covering from reproductive health, cancer prevention and control, infection prevention and control, multi-omics synthesis, basically reading and writing. And also we provide the total solution for building up laboratories, establishment, or any urgent testing inquiries, such as the Huoyan Air Lab for fighting COVID-19. So the second one is MGI. Currently, the first row are the sequencers manufactured by MGI. Now all of them are market available from small throughput until the large throughput. We also have our own library construction kit and also the sequencing reagent. The second row is our laboratory automation system covering from sample preparation, extraction, and also the automated liquid handling workstations, and also the library constructions as well. So we are also developing the new products such as the remote robotic ultrasound system, the pocket single cell lab, and also the BIT products, which represents we combine the biotechnology and information technology to create a one-stop solution for any of our partners who wants to launch the services in their own lab. And apart from that, we also provide a one-stop mobile testing laboratory solutions for the partners. And FGI is a forensic genomics entity from BGI Group. FGI provides world-leading, high-accurate forensic DNA testing to benefit society. And FGI innovates forensic applications through integrating industry, education, and research. FGI can provide a non-invasive prenatal paternity test, hair drug test, and forensic equipments. Your work has been used in many country natural disasters, including the 2004 Indian Ocean tsunami and the 2018 Laos dam disaster, and to help identify victims through DNA testings. BGI Medicine was founded to create the future hospital model with genetic technology as a core concept in the precision medicine and Internet of Things. A signing ceremony for the entrusted operation of the Shenzhen BGI Hospital was held on 2020. The hospital has been under preparation and construction since then. So the phase 1 is going to be finished very soon. The phase 1 will be still based on our current medical treatments, just like people feel uncomfortable and go to hospital to get the to find the evidence of the symptoms and then get treatment. But in the future, in the phase 2, we will be emphasizing on preventive medicine, try to use big data to predict and to prevent the individual from getting any diseases. And the next one is our global presence. Basically, we have our presence in every continent. And we already have our offices and laboratories in more than 100 countries. Now, like in Asia part, we have BGI Thailand, BGI Singapore, BGI Brunei, and also in Middle East, we also have BGI Saudi Arabia, BGI Dubai, and we are going to have BGI India, which is in process of registration. And our product services, BGI provides a multi-omics medical solution throughout the human life cycle. Basically from pre-marital, we can provide the carrier screening to the couples to screen, are they carrying any autosomal recessive diseases? If the couple carry the same mutation, we will suggest them to go for IVF in order to get a healthy baby, get a healthy embryo transferred. And if they doesn't have any risk, we go for natural pregnancy. At the prenatal stage, we also provide the non-invasive prenatal genetic testing to screen whether the fetus have any chromosomal aneuploidies. And in terms after when it gets to newborn stage, we also have the newborn deafness gene testing. We also have the metabolic disorder screening. I also provide the newborn genetic testings as well. So along the development of the individual, the life cycle, we also have the solutions provided in terms of any pathogen infection. BGI's PM-seq solution is normally we work with the ICU of the hospital to identify the unknown cause fevers. And when it gets to elderly stage, we also provide the tumor testings as in 3 main categories. The first one is early cancer detection. The second one is for the targeted drug treatment guidance. The third one is for the recurrence monitoring as well. So research and development, with more than BGI research, now we have more than 1,000 scientists in around 25 laboratories. BGI research now currently and separated into 5 different institutes. We have Institute of Biochemical Technology, Institute of Biointelligence Technology, and Institute of Precision Health Research, as well as the Institute of Cell Omics and Institute of Digital Earth, working on the sequence, categorize, and characterize the genomes of all Earth eukaryotic biodiversities to understand the origin, evolution, and biodiversities of eukaryotes. So yeah, these are the papers that BGI has published as the cover page on the Nature and Science, like the rice genome, panda genome, the first Asian genome, and also the gut genome. So along the development in 2021, BGI ranked #1 among all the life science corporations in Asia Pacific. And from the Nature Index in 2021, we also ranked #10 among all global life science corporations as well. And BGI College, BGI College is founded in 2011. It's mainly focusing on providing the joint training or joint diploma programs with the top tier universities in the world, like University of Copenhagen, Aarhus University, and City University of Hong Kong, and the University of Macau. So during COVID-19, actually before COVID-19, BGI has a successful history of fighting diseases, such as in 1995, we are the first HIV, we provided the HIV and AIDS testing kit in China. In 2003, we are the first one to sequence and providing the diagnostic kit for the SARS virus. for the SARS outbreak. In 2004, we are also first to sequence and provide a diagnostic kit for the avian flu. In 2011, for the German E. coli outbreak. In 2014, for the Ebola virus, as well as in 2020 for the SARS-CoV-2 virus. So we actually, during the COVID-19 from Wuhan, we used our experience from SARS in China in 2004. Our founder president Wang Jian bring the team go to Wuhan on January 25th, 2020. And in January of the same month, we developed and launched our nuclear acid detection kit. And in about 5-7 days, we built up the first largest 10,000 Huoyan laboratory for RT-PCR testing, which has a 10,000 daily throughput. And we also later on established more testing solutions and laboratories in China and all over the world. So this is one is during a later stage, BGI also innovates the inflatable one-stop solution for COVID testing. From the picture you can see, this is the one in Hong Kong, which is capable of doing 100,000 tests per day. And we also have the other integrated solutions such as container lab and also the mobile testing lab. And currently we already have around 90 labs in more than 30 countries. This like in Serbia, Australia, Kazakhstan, Canada, Germany, as well as in Brunei, Philippines, and Saudi Arabia. So our testing kits has granted, I think, the most accreditations such as CE, FDA, TGA from Australia, PMDA from Japan, and Health Canada, even WHO as well. And after the COVID pandemic, even it's getting, so the hunt continues. Apart from providing the RT-PCR detection kit, we also provide the RT-PCR kit to track the variants as well. So now we have a suite of mutation detection kits that can detect alpha, beta, gamma, and delta variants, as well as later on we also have the one for Omicron. The rest are our social, apart from doing business, research, and industrial development, we're also paying our efforts on the responsibility. Sorry? Is there anyone speaking? Okay, so I'll continue. So we also pay our efforts and to help the world. So in 2004, we helped to identify the victims of the Indian Ocean tsunami in Phuket. We also attended to follow and to help identify the victims in Wenchuan earthquake in 2018, as well as in 2011 for the E. coli outbreak, and also 2014 for the Ebola virus. Of course, in 2020, we are always on the front line of fighting COVID-19. The last one is BGI, the China National Gene Bank. We, as mentioned before, BGI is entrusted as the operator for the China National Gene Bank. So from the logo, you can see the China National Gene Bank consists of three banks and 2 platforms. It consists of the reading, writing, and storage, and also it consists of dry bank, living bank, and wet bank.
Thank you so much, Mr. Han. I really appreciate your detailed description and everything that you did for Pakistan. It was a pleasure having you, and thank you, BGI, for all your contributions. It is time to move to our next session now, and it is session 6 by Mr. Bilal Mumtaz, co-founder of Elaj. Mr. Bilal, please, I'd like to request you to stick to the time and do not cross 10 minutes. As soon as your 10 minutes are over, we will shut the mic off. Thank you.
Hi, my name is Bilal Mullaz, and I prepared a presentation today from the private sector of Pakistan working in health tech solutions. So what Elaj is a telehealth platform that specializes in medicine delivery and teleconsultations through an app and e-commerce site. And though we are currently selling antigen testing kits, we have not pursued any sort of genetic testing kits that are direct to consumer as of yet. Just a little bit about myself. Elaj was a merger between an online pharmacy Sayed and HealthCare. So I was co-founder of Sayed first, and then when the merger happened, I became a co-founder of Elaj naturally. I have also had a role in developing the e-commerce stakeholder market. So I'm a founding member of Pakistan E-commerce Consortium. I serve as the Secretary General of the Digital Health Association. We're working on passing a telemedicine bill at the nationwide level. And I serve at the steering committee, the ORIC, at the University of Home Economics as well. So just to give you a glance of how Pakistani e-commerce has fared so far, according to the latest State Bank of Pakistan data, we have around 3,003 registered e-commerce merchants. And our e-commerce transactions total up to about 21.9 million, whereas our transactions value is valued around 60.9 billion rupees. Then, through primarily insights provided by I2I, which is actually an incubation center based in Islamabad, we then look at how startups are fared. So there has been a boom after the COVID pandemic hit in 2020, where around $565 million were raised by Pakistani startups from 2015 to 2021. And you see that huge spike in 2021 with 352 million for the past 5 years ago. And 40% of all disclosed investors in 2021 were international VCs. So there's a lot of traction coming in from the international venture capital market coming in. And 55 deals out of 83 in 2021 had VC participation. You're seeing around double from the year before. Just a little glance, there's different areas in which funding can come in. Co-working spaces attract investment from native startups. Incubation centers are also one other avenue to consider. Slowly bootstrap startups also can attract funding. The most interesting one, I think that's most pertinent before I try to make a case with the genetics market and its scope, is that around 211 million of the 352 was in e-commerce, of which $33.7 million went into retail. So there was basically a DTC or direct to consumer. Direct-to-consumer market, it would fall under the retail segment of this space. You see 95 million going into fintech, 74 million going into trucking logistics. And these are just, some of the deals that come to mind, some of the investors that came in, and the ticket sizes as well. So I did have a discussion with a fellow Pakistani who was based in Denmark about developing a TC genetic testing kit that was not falling into basically finding out hereditary ancestry, but more to do with nutrigenomical analysis. And that basically, in a nutshell, in very layman's terms, means using DNA testing to figure out what kind of diet or what kind of wellness plan best suits you. These are essentially his details. You can even get them from me later. He's not working on it right now, but I'm sure if there was a platform for him to develop this product in Pakistan, I'm sure he'd be happy to reach out to any of you, especially those at the Health Services Academy. So when we're talking about developing this product, what was this problem? The problem was most direct-to-consumer DNA companies fail to fully engage their customers and keep them interested in a product over time. I think the most common example of this is seeing ads for services like MyHeritage, where they say that, oh, you can, order your DNA test and even send it to Pakistan from the States. And then you can find out, your genetic makeup. People might be fascinated to learn that, you might be Pakistani, but let's say some of your genetic makeup is, some of your ancestors may have come from England, from Iran, from Japan, from all over the place. Now, when it comes to the direct-to-consumer customers, the users of DTC test products reported that viewing personal genetic risks made them think more carefully about diet, exercise, and health, but they lack professional advice on taking preventative healthcare measures. And currently, no solution exists in Pakistan, at least, to fully engage the consumer as well as advise them on actual preventative healthcare measures while taking their genetics into account. Now, that brings into mind what the solution is. The solution is to empower users to make better informed decisions about their health. Genetically, human beings are around 99.9% the same. It is that 0.1% that makes us unique. Finding out what makes us different gives us unique insights in our body. And that could be, just by quoting a simple example, that it turns out that 70% of human beings out there are protein efficient. 20%, 25% are then carbohydrate efficient, and the rest are fat efficient. So that also keeps in mind, that not everyone is built the same. We might say that, oh, if you want to lose weight, if you want to build muscle, go on a strict protein diet, but not all human beings are built like that. And for most people, there's a large gap between access to at-home genetic tests and access to genetic counseling. The users of direct-to-consumer test products reported that viewing personal genetic risks made them think more carefully about diet, exercise, and health. A healthier you through genetics and preventive measures is what Genomium provides. But also with that, online counseling should be given with geneticists, psychologists, medical doctors, nutritionists, and fitness coaches, where certain goals regarding weight loss, improvement of fitness, improvement in overall health, and enhancement of performance and reduction of stress can also be put into consideration. Value proposition is very clear. This was pitched around 2019, and that the global DTC or direct-to-consumer gene testing market is supposed to be valued in excess of $1 billion by 2020. And how it works is very simple. Customer orders a subscription of the product, send the kit for a buccal swab, which goes in the mouth. Customer follows the instructions, sends the kit back to the lab for analysis. In this case, the lab would be outside of Pakistan. We educate the customer during the wait time of 4 to 6 weeks, fully engaging him with sample reports on how to understand these reports. Results come back, one-on-one counseling starts, then sessions are a focal point of goals to be achieved. Subscription ends, and then a lot of cross-selling can happen. So that's why e-commerce and entrepreneurs can play their part in cross-selling certain vitamins that can be coupled with the assessments given by such genetic tests. And this is a very basically simple customer journey, which can be fulfilled very easily through e-commerce. And now we go to how the market is actually fared. There's an online gene testing market report that I'd like to quote. The publishing date was very recent. Around 80 companies were covered in around 18 countries. So what we then see is the online platform segment and the over-the-counter segments are two concurrent segments of how these direct-to-consumer kits are sold. And 50.5% is the average growth rate for online, and 30.2% is for OTC. And as you can see, the market value right now is around $1.4 billion. And the technologies used either comprise of S&E chips, predictive testing, or WCS segments, as shown over here. And these are the different sort of tests you can come by. Carrier testing means getting a test done to see what hereditary diseases you may have. Predictive testing is getting a test done to see whether you're at risk for a disease like cancer. Ancestry and relationship testing comprises the majority of the gene testing market at 40%. Nutrigenomic, which was covered basically through the use case of genomium, is you getting your genes tested to see how you can better your wellness. Skincare testing is another segment, and others fall in the latter category. And this sort of told you the technologies that are in play and their shares of the market. And interestingly enough, what actually makes this very lucrative in Pakistan is that in 2018, as opposed to what will happen in 2028, it was discovered that 71% of the market in value was done through online sales and not OTC sales. And that market share will be 81% in 2028. So it's already an online dominant market, which invites calls for entrepreneurs to come in and to sell it, through a mass medium online as people get more educated.
Thank you, Mr. Bilal. Thank you very much, Mr. Bilal. We'll move to the next speaker. He's Dr. Jurgen Feuerstein from the Netherlands, SPL Medical University. And his session will be treating cancer earlier and better to save lives. So can I request Dr. Feuerstein from the Netherlands of SPL Medical to start the session and keep it as brief as possible. We have 10 minutes before our break. Is he connected? Can you hear us, Dr. Feuerstein?
Yeah, can you see my presentation?
Not yet. Can you
Not
share
yet.
your slides,
So
please?
it should come in a second. Just
All right.
a second. Then we would be able to show it.
All right, we can see you.
Can you see it now?
Yes, I guess we shall be able to see it in a bit. It says you've started. Yes, we can.
Very good. So thank you very much for giving me the opportunity to present at this prestigious conference. Thank you very much to the honorable sponsor and chairpersons. I want to tell you and show you today how we can save lives by visualizing metastases and inflammatory activities earlier and more precise. We are SPL Medical in the Netherlands, together with the Nijmegen University, and in Pakistan, we are represented by DRM Pharma and Diagnostic. Prostate cancer currently is setting a couple of issues in its diagnostics and treatment. Most metastatic lymph nodes are smaller than 8 millimeters and cannot be detected with conventional scan methods, and also with more elaborated scan methods due to physical restrictions. However, the majority of important metastases are smaller than that. And also a surgical exploration misses up to 30 to 40% of the lymphatic metastases in the prostatic cancer. Here you can see from literature that patients with a smaller lymph nodes metastases have a far better survival chance than patients with bigger lymph nodes. And this is not just a couple of months. As you see here, we are talking about many months and even years. We have experience with patients where the lifespan has been extended to more than 5 years. In this example, you can see that the postoperative lymph node, the important lymph node, is still there. So although the surgeons have done everything they could, they still have to leave some of the metastases just because they are not visible, or because they are in dangerous areas, have to leave them back. And this is what we see. We see preoperative, the very tiny lymph nodes, and postoperative, it is still in the body. And this is then causing harm and disease progression. On this image, you can even see more precise. Have a look. These very tiny, small items, which you see highlighted, are the very small, tiny lymph nodes that cannot be detected with any other methods. However, with our methods, with nano-MRI, with Ferretran, we're able to detect them on any MRI machine that is available in the market. No extra support or maintenance or whatever needed on the machine. It's very simple. It's the Ferumoxtran, we call it Ferrotran. It's being prepared, weight adapted to the patients, administered intravenous, and then there is an MRI scan. As I said, can be done on any machine. The pooled sensitivities and specificities are very high. Here's a literature overview that shows you we are in the range of 88% sensitivity, 90% specificity, which means a huge area on the plot. So there is a high diagnostic efficiency of the method nano MRI with Ferrotran. The method can be used for selective targeted surgery or radiotherapy. Here I bring you an example of radiotherapy. What can be done, as we know precisely where the metastasis is, which is causing the further spread of the disease, we can irradiate with very high intensity on a very limited area, by that increasing the efficiency of the treatment very much, but also decreasing the potential side effects dramatically, just because the healthy tissue is not affected and it's all focused on the spot of interest. Nano MRI is even superseding the current used PSMA PET. There is literature published that shows on the basis of 45 patients with primary or recurrent disease that significantly more suspicious lymph nodes have been detected, and these lymph nodes have been on average smaller ones, which is logic because only with our method, with the nano MRI, we're able to securely detect the very small lymph nodes. So there is a significant benefit. And how does it look like in a practical example? Here you see a lymph node of 4.5 millimeter, which is even way above our limits. We can go down to 2 millimeters in normal routine MRI machines, but even below 1 millimeter is feasible in very special occasions. It is very well visible with nano MRI with Ferrotran. On the other hand, with other methods, the most sensitive being PSMA PET, it's not visible at all. Here you see the overview of the literature just mentioned. In green, nano MRI, in blue, PSMA PET, and you see the big difference in the distribution of the lymph nodes and also the much bigger number of lymph nodes. So many more suspicious lymph nodes has been detected and they are significantly smaller. So you can start the treatment earlier and more effective. All in all, as a summary, with nano MRI with Ferrotran, we are able to treat cancer earlier and better, and we are able to show and distinguish metastases already at 2 millimeter size with MRI machines that are available at the market. No special equipment needed. It's just the agent Ferrotran that has to be adapted to the patient, and then it's a normal conventional scan with sequences which are available on all of the machines which are out there. Of course, it is better to use the more modern machines. 3 Tesla is exactly the same diagnostic sensitivity and specificity as 1.5 Tesla, but the acquisition times are longer, so the patient would have to stay longer in the machine, the lower the magnetic strength is, but the diagnostic efficiency is the same. So it's available and applicable to all the machines which are available in the markets. So I thank you very much for listening. I think I was very well in time.
Thank you very much.
And,
thank you very much. You were the only one who respected time. Thank you so much, Dr. Kirsten.
My pleasure.
Thank you very much. So we proceed to the break now, and then we can resume it at 2 p.m. Thank you very much for listening.
हाँ वो मेरा एक फ्रेंड ने किया था इसलिए मैंने एथिकली उसका नाम वो सर मैंने भी उसको ये मशवरा दिया था इंशाल्लाह मैं किसी एकेडमिक लिंकेजेस को actually strong बनाना चाहता हूँ मैंने भी अपने फ्रेंड को बताया था कि ये मैंने भी फॉर एग्जांपल my head is a test लेकिन एक 2 हफ्ते लगते हैं यहाँ
That's ICESCO. So thank you, Dr. Rahil Kanwar. We move on to you to start the session on gene sequencing, and please keep it to 10 minutes because we are very, very limited on time. Thank you. Is Dr. Rahil, can you hear us?
Yes, I can hear you.
Right. So let us start the session, Dr. Rahil. Thank you.
Well, thank you very much for this opportunity to talk to you all. I thought, since my topic was on DNA sequencing, I thought I'll give a couple of examples of the power of sequencing and what can be achieved with this. In another life, quite a while back, I was working on the population genetics of Pakistan. I think somebody earlier talked about the commercial applicability of this also. We have shown very clearly that most of Pakistani population, they originated in the Central Asian states and migrated into Pakistan with the following a second migration, which took place from all the way from Turkey into Pakistan. So we are a sort of mix of these two populations in Pakistan, except for some minor differences where the Brahvis are completely Dravidian and the Pathans have about 5% genomic contribution from the Greek, and Parsi have Zoroastrian DNA in them, and the Makrani have African DNA in them. Besides that, everybody else is almost the same. This one particular group, which is found in Parachinar and in Quetta, which are known as the Hazara, I was working on them and I found them to be completely different from the rest of the Pakistani populations. They did not match anybody at all. And their DNA was so unique, their Y chromosomal DNA was so unique that it fell basically under 2-3 different models which were interconnected to each other by single mutations. So saying to us that this DNA is probably not that old. So what we did is, I was at Oxford University at that time, and one of my colleagues, she had collected samples from the Central Asian states. And I asked her, Tatiana, do you see this same sort of an effect in Central Asian state? And she had not done the experiments at that time. So she went back and did the experiments. And what we found was we had a 100% match with 5% of the Central Asian state people. And what we did is we did a technique known as dating the chromosome. So we dated the chromosome and it came out about 1400 years ago. And we looked into history, and 1400 years ago, obviously Genghis Khan was in this region and he was going around and he was spreading most of his DNA. And we proposed that also and submitted the paper to Nature, but they said you don't really have enough evidence that it was Genghis Khan or somebody else. So we reformatted the paper and called it the Genetic Legacy of the Mongols and published it in the American Journal of Human Genetics. After a while, one of our collaborators, he went to Mongolia and he dug up some of the, some of the skeletons from the great-great-grandson, I think it was, of Genghis Khan. And he analyzed that their DNA by sequencing, and he found 100% match with our DNA. So it is now certainly confirmed as this was Genghis Khan who was, spreading his genome in this Central Asian state and in Pakistan and Afghanistan and so on and so forth. So this is one of the most powerful example of genetic testing and sequencing and showing the effect of the spread of this single human's DNA across such a wide region. 5% of the genome, that is a huge number. And it was really unexpected. We were not expecting to see that, but we were very pleased that our theories and all those things had come out true. So this work, like I said, was published in the American Journal of Human Genetics, and it is called The Genetic Legacy of the Mongols now. Previously, we had submitted it as The Genetic Legacy of Genghis Khan. But like I said, that was rejected. Second example, I'm basically a population geneticist and disease geneticist. And in population genetics, I've worked on different world population genetics and Pakistani population genetics also. And it is very clear that human population basically began in Africa. And then they migrated out of Africa about 50,000 years ago, and the people in different parts of the world. And at that time, there were other hominins present on this planet also, especially Neanderthal. Quite a significant number of population were present in Europe, ranging from about 430,000 years ago, when there were no modern humans on this planet. Human population, basically us, modern human, originated only about 200,000 years back in the Great Lakes region. So Neanderthals were there before us, as well as other hominins like Denisovan man and Java man and so on and so forth. And the Neanderthals, they coexisted with us humans for about 10 to 20,000 years, because we were in Africa, we were in Europe about the same time period that the Neanderthals were there. And in the Far East also, including China, Japan, and other East Asian countries, we sort of coexisted with the Neanderthals. And we geneticists, we always thought, there is no way that there was any cross between Neanderthals and the humans, because they're two different species. And just like when you cross a donkey with a horse, you have a mule, and the mule is obviously infertile and cannot pass on its genome. So we thought that is probably what happened. If there was even a cross between these two species, their offsprings were mostly infertile and the genome did not pass on. Lo and behold, when the Neanderthal genome was sequenced from Europe and all that, what we found is 1 to 2% of the European, 1 to 3% in fact of the European genome consists of the Neanderthal genome. And that was very, very surprising for us. And when we looked at the Far Eastern states that I mentioned earlier also, they had even more Neanderthal DNA in them, more than 20% more than the Europeans. So that was very, very surprising. And when we looked at the Denisovan man's DNA contribution, that was mostly found in the Pacific Islanders and South Asians. And that was very little. That was only 0.005%. So all these hominin species which coexisted at time, they really passed on their genes or genomes to each other, especially to us modern humans. And some of these genomes really contribute to our, for example, to our overall immune system. There's a very significant contribution of Neanderthal DNA. And our sensitivity or lack of sensitivity to UV radiation is also contributed by them. Some of our populations are more prone to heart diseases, and that is because of the Neanderthal genome, and so on and so forth. A lot of genetic contributions are there, which either provide us susceptibility or provide us immunity against certain diseases. And I often wonder, that if you look at the COVID spread also, I think I read a paper a long time back that people who had Neanderthal genome in them are more susceptible to COVID. And if you look at the COVID situation in the Far East and in Europe, you would find it very, very high, at a higher frequency as opposed to Africa. In Africa, it's at a very low frequency. And similarly in Southeast Asia and so on and so forth. In Pakistan also, it's not that high a frequency. So, we thought that maybe this was going on. And then people were postulating that because Neanderthals did not coexist in Africa, so there would be no genetic contribution in Africa of Neanderthals. But again, lo and behold, when the genome was sequenced, there was, a significant contribution. I think almost, if I remember correctly, it was 0.3% of the African genome. So what was going on when they were really not coexisting at the same place? What was going on? The theory of human migration is called out of Africa. So human came out of Africa and people different parts of the regions of the world. But there is a back to Africa sort of theory also, which had not been, confirmed before. But this very clearly showed that the presence of the European Neanderthal genome in Africa showed very clearly that was some back migration from Africa from Europe into Africa also.
And of course, since the Native American population originated from China, when the last ice age happened and there was a Bering Bridge formed on the Bering Sea, and they have a significant population of the Neanderthal DNA also. So this just shows you that even after, in Genghis Khan's effect, 1400 years after the fact, and in Neanderthal's case, even after, 30, 40,000 years after they had even vanished, we can still trace these genomes and this DNA in the modern human. And it really amazes me sometimes that the power of genetic sequencing, how much information it can reveal to you. Anyway, so thank you very much, everybody. I think my time is up. If there's anybody wanting to discuss it further,
Thank you, Dr. Rafi Samar. It's very, very nice and interesting to know that we're all descendants of Genghis Khan somehow. But thank you very much, and thank you. And let us move on to our next session now. So session 10 with the NeoSoft project by Mr. Rex and Mr. Dan. NeoSoft Medical System. Can Mr. Rex hear us?
Yeah, Dr. Zara, I want to have just a brief intro of it. Since NeoSoft is going into a very strategic project in Pakistan. The project is called National Imaging Technology Project. It is a China relationship development project, and what we are trying to build, which Mr. Dan, Mr. Rex will talk about, is that it will change the overall holistic approach of imaging technology. Now that in which Pakistan is going through a very overall serious situation. So what we need is that development of capacity and aspect of our current health society. So that's what NeoSoft has a vision to develop it over here, not only by providing the equipment, but providing the capacity building of its preventive maintenance in this, thus providing the development of the local manpower, and with this, eventually the second stage for the CKD manufacturing, not very far from here, from the newly developed ST which is the backbone authority in the second phase of the project. So over to you, Mr. Dan.
Hello, thank you. Thank you, Mr. Mir, for the introduction. And my name is Dan Zhang. I'm the Vice President of International Business, NeoSoft Medical Systems, and your honorable guest. And thank you for sharing the healthcare situation in Pakistan and how we can collaborate together and to make the future better. Can I share my screen? Okay, here we are. Can you see?
I think in a moment we should be able to. Yes, we can.
Okay, thank you. Let's give you a very brief introduction about the NeoSoft, who we are. And actually, NeoSoft stands for Northeastern University, which is one of the largest and comprehensive university based in Shenyang. It's the northeastern part of China, and 1 hour fly from there to the north from Beijing. And we have 3 business domains. I come from medical devices. I come you later. And we are one of the largest IT provider in Asia, top 10, and the number 1 in China. We have more than 30 years experiences in the medical IT as well. And we are the first listed company, software company in China, Shanghai Stock. And also that we are engaged in the education because we're from university. So we are created 3 universities dedicated for the information technology and different part of China. And also that we are engaged in the business of medical devices back to 1997. We started manufacture a CT scanner and then MRI, ultrasound. That is 4 major modalities for the medical imaging. And in education background, and we have 3 universities, which is dedicated for the information technology. And you can see that every year that we provided the education program for more than 34,000 students. And quite a number of the students and dedicated for information technology, and we pulled out to the in different area in China, and also we have the biomedical degree, which work together with Netherlands, and also that we have a medical imaging training program. I think that is one of part you could be interested in later on. And also that talking about the IT, because Newsoft is given the task to manage 1.4 billion population, which is our total population of China, and to maintain their database. That means that the identification card are maintained by Newsoft. And also we have 700 million people are using our security, social security program. And this program is implemented 20 years ago, and now it's working perfectly, and we reduce significantly the reimbursement and from the 3 months to today only 10 days. So that is a huge contribution to China social security program. And also, I will not go through all the numbers, but you can see that we are maintaining the big data in China. And back to medical, which I come from, and we are probably the only 2 companies today in the world provide medical imaging modalities and also cancer treatment, and also intervention therapy equipment. So you can see that from the CT to MRI, from ultrasound to PET CT and DSA, and also the IVD, and all are manufactured by Newsoft. And of course, that we see that is the tools which can help the people to get prevention in advance, which are saving a lot of our financial resources at the end. And this is our global presence, and we have more than 10 subsidiaries in different parts of the world, and to make sure that we are very close to our customers. And also we're working very closely with our business partners, and to make sure that our service could be delivered in a very professional way. And we've been in Pakistan for years, and we've been well known in the open MRI, and also recently we have delivered CT, and we start working together with our local partners, DA, and to find the very cost-effective solution to provide those modalities in the area which people need, and also that using affordable way to achieving our goals. I think that the guest already mentioned many challenges facing today's healthcare systems. We are not big difference. I think that China, as one of the biggest developing countries, we're facing challenges the same as yours. And those things need to be tackled, and those challenges need to work together across the countries. I think that I hear from the other guests at the panel, they're all sharing that how we can collaborate. So we present our solutions back to 2 years ago, and to the different level of authorities in Pakistan, and also in my country as well. And I think that probably it's the time to deliver it, to move in action. I think that this is quite known that you're all experts in the healthcare industry. I think that is your ambitious tasks. And I think Newsoft and would like to participate with local partners together and to make this happen. First, I think that as we are specialized in medical imaging, so I focus on this industry. We focus on this the goal which we both want to achieve. That is, we want to build together with our local partners, and through, of course, the government, the local authorities, the provincial level, and to build that network, medical imaging network, which can make the today's technology affordable and also stable, and also the access to healthcare, the good quality access to the good quality access, so the healthcare could be accessible. So that is our goal, and that's why we build together, and we have this plan. And back 2 years ago with our local partners, even this COVID-19, this pandemic, we still move on. I think that is the goal can achieve quite numbers of objectives: prevention, strengthening, enhancing, affordable, decentralizing services, For time being, I'm not going through every topics, but I think that is the key solutions, which is tackle the challenges we mentioned earlier. And this is the how we move from today. So we're going to upgrading the current systems, which we work together with our local partner DA to build a joint team to go through the public sectors, especially the hospitals in the rural area, to see what they really need. It's not only the system itself, but the people, the resources which can using the systems, and to make to fully realize the potential of the systems. It is a total solution. So we have to make the local research carefully and to give accurate solutions, not just you take this and go. It's not that it cannot work. So we have to make sure that we understand the people working in the front line, what they need really in rural areas. And also that if we can build this together, and that's a huge contribution and to the national health, especially for people who deserve to have, to get access to the quality services. I think those areas we already identified. Our local partner DA already sent a team to look at it, to hear, to listen from local users. And then the most important is training.
Sorry, because this is such a significance now, and since this is record auditing, and there would be a strong takeaway. I wanted to go take it from this place to the highest level. Now, one thing you guys must be custom of the facts of the fact of what you're there and trying to mention. That the gap analysis between the diagnostic direction on pre and post, meaning what was Bombay, or sorry, Dan, I'm just telling the PDM over here, or Jabusti Tashkish Sweeney. So I'll just give you an example. I was last week in Lahore, a friend of mine, it is a reliable center. He himself was in the DIG Lahore. He was talking with the DGL. He called the guy to his friend, who is supposedly also my friend, who is and he said that my driver was ill and he got a stroke. So I wanted an angiography. And you have obviously both comes under the public domain, public health. So the guy called him, called the DG, and he said, okay, yes, it can be done in 2 months' time. Remember, one is a DIG and another is DGL. So their call, if it makes 2 months to the person who even do the angiography, automatically come here. And remember, sitting in the AC room over here, we're sitting in all the privileged class we have. There's 70–80% of them is not even accustomed of having that call to anyone. So what NewsSoft is trying to do so, if our health gurus or health corridors understand that we are trying to build an ecosystem, not that by selling the machine, not that just providing it, but develop a sustainable eco model system, which as Investor Nazmana of China mentioned it, that the Chinese system, the success of the Chinese in the last 30–40 years is not from building the dams, not from building the highways. It comes from their strong mindset from their ecosystem, which comprises of health and their social economic development, which drives everything in. Sorry, Dan, please go ahead.
Thank you, Mr. Mears, and you are showing our real situation that you're added very valuable comments. The most important training program, and as take advantage of being the university, and we provide very comprehensive training program from A to Z regarding the medical imaging, and we're very happy to find local partners and through the DA to see who is interested in building this training stronghold in Pakistan. And also, I think that is are good and for the long run, and especially we can have, the Pakistan has lots of talent in software and also in medical. So how we can build that strength that even not only for the country itself, but also can help in the neighboring countries. So that is I talk a lot with Mr. Mir during the meetings here in Dubai and in other places we have this face-to-face meeting. We both are focused on the training. So that is could be our even before that we implementing the hardware. So we have to be more aggressive in building these training facilities together in the free zone. And service maintain, and this is one of the most important for these big capital equipment. And we should not stop in an hour. So we have to build the services team locally, and also we see that we also want to train the qualified engineering in Pakistan, and I think that these are also part of the training as well. And financial solutions, and that we have this budget already, and with the banks and in different countries, especially in China, we have our financial supporter, and also we talk to the financial organization in Pakistan and to see how we can link together by using this soft loan or low interest commercial loan to help this project to move forward. And I think that will pay off after the couple of years, and we will see how significant changes by having these financial tools move out for faster. And this is one of the successful cases, and that has already happened in Kenya, in East Africa, which is one of the very developed countries in part of Africa, and they are facing the same challenges back to 5 years ago. So they're now thinking the implementing the whole national screening program, and they are searching the partners. We are one of them, and of course that they are a couple of our partners and to pursue this project, and we finally will win. We win is not the project; we win the heart of the people who are in front lines in the country, and we provide this whole total solutions and to giving them this over 1 year. So the 37 counties receive the systems and build a national network. And even in this COVID-19 pandemic situation, this help a lot. So they covered 76% of the population in the country. So almost all the patients don't need to go to hospitals in capital, in big cities, in Kisumu, in Nairobi, in the Mombasa. So they can enjoy the services inside their county. So that is our important progress. That we already make progress, and since the 2020, we signed our MOU with the Dynamic Engineering and DEA, and also we have His Excellency Ambassador Morin to visit Newsoft the last year, and to see the project, and also see us to try to understand more how this will move. So I think all of these are showing that we are ready, and I hope that this meeting are one of the demo that we would like to continue with our local partners moving more faster.
Then we will do that. If you could give the closing remarks before we just move on to the next session.
Okay, thank you.
Thank you so much. Thank you, Mr. Dan. Would you like to say something? Okay. So from Mr. Dan, thank you very much. And he spoke about winning hearts. Definitely Neosoft is winning hearts. And we did see that during COVID as well, when ground glass appearance and CT scans were way more than PCR. Well, now the power of exome sequencing for the diagnosis of genetic condition by Dr. Gabrielle Hens, Germany. Can we move to Dr. Gabrielle? Can you see and hear us?
So can you see me and can you hear me?
Yes, we can hear you. If you could share your screen, please.
Yeah, I start sharing my screen. So, and hope you will see
yes,
it.
We can see it now.
Oh, perfect. Thank you for the invitation and a warm welcome from Germany. So within the next 50 minutes, I try to convince you that exome sequencing is a rather good tool for the diagnosis of genetic conditions. We already had in the morning some genetic talks, so this is another one. So first of all, I will give you some geographical information. So we are located in the southern part of Germany in a little academic town called Tübingen. And we are a rather new company, which I think we are now exist since 12 years. And this is my boss and the founder, Saskia Biskup. And what our goal is that we keep everything in-house. So we start with a wet lab process in our genetic testing, and we have our own bioinformatic analysis department. And then finally, we produce the medical interpretation, the report. And so no data are stored in any clouds, etc. So everything is inside. And our goal is really to offer the patients comprehensive genetic testing pipeline to identify at least the genetic cause of their disease. So just to give you some background information, since last years, the next generation or high throughput sequencing is the golden standard in genetic testing. There's another. Could you please switch off your microphone? So okay, and so there are actually two main approaches in next generation sequencing. Since many years we perform diagnostic panels. What does it mean? We had the talk of my colleague from Blueprint in the morning. He also mentioned how diagnostic panels are used in genetic testing. Here you sequence in parallel all the genes known to be associated with a given disease or a group of disease, like epilepsy or retinitis pigmentosa, where we know that 100 or 200 genes are involved in a given disease. And so you can sequence all these in parallel and then maybe come up with a pathogenic variant and prepare a report. During the last years, recently, whole exome sequencing is become more prominent. What is done here? So what is an exome? We know since many years that we have around 23,000 genes in the whole genome. And part of these genes, it's called the coding regions. This is a part of the gene which is really transcripted and translated into a protein, which is a functional unit in the body. And this coding regions is the part of this coding gene is about 1.5% of the human genome. So all the other things are not coding, but they are also important because they have a really important role in regulating all the expressions and all the function of these genes. What we know since many years is that if you sequence all these the coding regions of all these 23,000 genes, you have a chance of about 80 to 85% to detect the causative mutation within these regions. So you can really look into every of these genes, and you can also do filter out genes you are interested in. We have our own exome system, which is not off the shelf, and have also included non-coding pathogenic variants, which is normally not part of the exome sequencing when you buy an off-the-shelf kit. We have an improved detection of mitochondrial variants. And what we also do is we are now rather good in detection of CNV data. So we can, so it means deletion duplications. So we don't need to run a microarray as an additional test. So so our idea is really to have one system where we can cover as much as possible. And what I like to introduce to is the power of trio exome sequencing. I come to this in a second. So I think that when we run our exome, we can filter for gene panels. So this is included. If we do trio exome sequencing, we can also detect uniparental disomies. And as I mentioned, we are rather good in detecting mitochondrial variants. We can detect duplication deletions. And of course, you can filter out single genes. So it depends on the question whether it makes sense to use exome sequencing for single gene testing. It depends on the size of the gene. In trio exome sequencing, you include also the exomic data from the parents. because if you have a patient which is affected in this scheme, it's a child by a genetic disease, and both parents are healthy, so the genetic cause has to be a de novo variant or a variant where one mutation is coming from the father while the other is coming from the mother. And so you have really a powerful way to filter down the relevant variants. And it's published and known since a couple of years. Then if you include the exomic data from the parents, you can boost your detection rate significantly. So in this publication, you come up with a solution rate of 37%, and doing a single exome, it is significantly lower. So this is an approach we try to use as a golden standard in our hands when it's possible to get the parents also as part of the genetic test. So I will give you two examples which are really examples. So first of all, often people run microarrays to detect for pathogenic deletion duplications ahead of exome sequencing. And we think this is not necessary anymore if you have a good bioinformatic pipeline. This was an example of a girl with age 1.5 years and had a global developmental delay, especially focused on speech and motor delay, has a microcephaly and no other dysmorphic signs. We had also included the healthy parents into the test, and this is the result. So I give you short explanation. It's not easy to understand. So ahead at the top of the scheme, you see the chromosome 70, and down you see this line with the blue dots, and the upper panel is the affected patients, and then we have also the mother and the father. And the dots are normalized number of reads in next generation sequencing. So it is just the number of reads calculated. There's no sequence information in this in this analysis, but you see this in the index patient, you see this yellow dots, which are dropped to the dashed line. That means we have here significantly lower reads in this part of the chromosome. And this is typical for deletion, and which is not seen in the father and in the mother. So it's a de novo event. And if you zoom in, you will see that this is a 288 kb microdeletion at 70p. And this is a size where you normally use microarrays to detect these kind of deletions. And if you start to make to check for this deletion, it is a well-known microdeletion and it's consistent with the phenotype. So we could solve this case with our exome sequencing, and we know that it's a de novo variant, and so no microarrays are not required anymore. But back to the regular exome sequencing, this is one of our most famous examples. Often genetic is a little, people are skeptic with genetic because they have no therapeutical relevance, but this is not true in all cases. So this was a really young girl and had a bone marrow failure, and we know that must be some genetic background because he had an older brother who died at 7 months with almost the same symptoms. And in a hospital here in Germany, the only way to save the girl's life thought was to do a bone marrow transplantation, and they established that the chance of survival was around 50% due to the young age of this little girl. And we decided to do a really fast exome sequencing, and that was the result. We found a pathogenic homozygous pathogenic variant in the gene TCN2. And this is a vitamin B12 transporter. And as you can imagine, there was a lot of metabolic screening before, and which come out negative. Was typically for this transporter defect is that in the blood you have normal vitamin B12 levels, so it was not possible to see it from the metabolic screening. From the kind of variant we found, we had the idea that that this transporter has at least a little minimal transporter function. So it was not like a zero function mutation. And so we decided together with our colleagues from the hospital to get to treat Layla, so what's the name of this little girl, with high dose of vitamin B12. And luckily we were able to really solve the phenotype. And this is, I think, 1.5 years later, and she developed normally, and so the trioxime was able at least to save the girl's life. And now I think it's 2-3 years later, and we know that she's still developed normally, and so it's really a powerful technique, even sometimes with therapeutical benefit. And we now are so feel safe with this approach that we are now using this also in a prenatal testing. And recently we had published the first 500 cases. We now have more than 1,000 cases where we use trio exome sequencing also in a prenatal setting, where you have only limited information on the phenotype. And we could solve 37.8% of these cases, and we found UPDs and mosaicism and also CNVs and mitochondrial variants in these cases, which are here I only talk of likely pathogenic or pathogenic variants. Otherwise, the variants of unknown significance we would not report in a prenatal setting. So it's really also a powerful tool in prenatal setting, and we are able now to have a turnaround time from 10 to 12 days. So it's really a fast tool, and it works really quite well. So that comes to the conclusion. We are think that the exome sequencing is really a powerful tool in a genetic disorder, especially of syndromic disorder, where you maybe have no really clear idea of which gene is affected. And we can use one exome for a really wide range of clinical cases. We don't need microarrays anymore, so we're able to detect losses and gains. And we have already some cases where we could detect pathogenic variants outside the coding region. And we run our exome with a high coverage to detect mosaicisms. And also, if you include the parents, you are able to detect uniparental disomies. And it works quite well also in a prenatal setting. And
thank you very much, Dr. Gabriel.
Thanks. Yeah, thanks for your attention.
Thank you so much, and telling us the power of exome sequencing to release us from the repetitive cycle of disease and death. Moving on to the next session, clinical genomic diagnosis to fulfill precision medicine by Ms. Jin An of South Korea. So you here is Ms. Jin. Thank you. Thank you. We can see you. You can share your screen now. Can you hear us? All right. Ms. Jin, I think you need to unmute yourself. We cannot hear you. Can you unmute yourself, please?
Can you hear me?
Yes, now we can. Please continue.
Yes. Can you see the full screen?
Yes, we can.
Yes. Good afternoon to all. First of all, thank you for sharing the healthcare situation of Pakistan. This is Jean from GC Genome, and it's my pleasure to meet you all today and get the opportunity to introduce our company and services. Genetic test was quite new in Korea just several years ago, but now it is rather commonly used in many hospitals than before. According to the article about perception on genetic testing in Korean medical doctors, About 80% of doctors are now utilizing genomic testing or even willing to use genetic testing results for their patients in the near future. Genetic testing are now utilized in diverse diseases, including cancers, autoimmune diseases, and so on. At the core of this trend, there is GC Genome, the leading clinical genomic diagnostic company in Korea. GC is one of the largest pharmaceutical companies in South Korea. Within GC groups, there are many family companies and they could be categorized into healthcare part, overseas part, foundation, and pharmaceutical part. GC Genome belongs to the healthcare part. Our company was established in 2013 and last year's revenue was $15.5 million. Our head office is located in Yongin and currently more than 100 employees, including 6 medical doctors, are working here. All of our tests are performed in-house and interpreted by our internal medical doctors. Our service could be classified into largely 4 sectors: precision oncology, rare disease, prenatal, neonatal, and health checkup. We have specialists in each field: medical doctors, sales specialists, medical technologists, and strong AI and BI team. We do have #1 market share in South Korea. We are mainly providing our services to university hospitals and tertiary hospitals. We have over 100 kinds of human genomic tests, and we have 9 years of experience in genetic testing so far. We also formed global partnerships with diverse overseas companies. By expanding our global network, we wish to increase our capacity and reach out to more patients in need, also include Pakistan. As for our vision, we pursue best-in-class, first-in-class, and ultimately drawing on expertise in genetic diagnosis to develop gene therapy. One of the difference points from many other sequencing companies is that we really do focus on research and development also. As you can see here, the number of papers we publish every year has been steadily increasing. We also have diverse patents in our test and AI and BI algorithm. We are also engaged in many government projects. We have been working together with many government institutions and university hospitals also. For example, we are participated in several liquid biopsy projects like developing the liquid biopsy test to predict response of anti-cancer therapy. We are the first to obtain CAP accreditation in Korea as a non-medical institution. We also got an A grade, the best grade in accuracy of genetic testing. We are also assigned as clinical NGS laboratory from KFDA. As for the sequencing platform, we have NextSeq, MySeq, NovaSeq from Illumina, and DMB-Seq G400, DMB-Seq T7 from MGI also. As I mentioned earlier, our service could be classified into 4 sectors: precision oncology, rare disease, prenatal health, neonatal health, and health checkup. I will explain each of the services just in later slide. As for the prenatal test and neonatal test, we have comprehensive portfolio for the woman who is planning for a healthy baby, for the fetus, and for the newborn babies. Fragile X syndrome test and myotonic dystrophy are kind of prenatal screening tests for the woman planning for a healthy baby, and NIPT is an accurate prenatal test to screen for fetal chromosomal aneuploidies. iScreen is an essential test needed after babies are born for their healthy development. As you may know, fetal DNA is circulating freely in mother's blood. And this kind of cell-free DNA could be used to test for major chromosomal aneuploidies, including Down syndrome, Edwards syndrome, and Patau syndrome. It is non-invasive and thus safer than conventional amniocentesis, but the important point is that the accuracy of NIPT is as high as amniocentesis. We provide 3 options: NIPT Lite, Basic, Premium version for patients to choose from. iScreen is a newborn genome screening test, and it screens all chromosomes for more than 19 genomic disorders. It is hard to prevent the occurrence of genomic disorders, but early diagnosis and treatment may help babies' health. Just blood paper or 0.5 cc of blood is necessary for this test. DES, WES, and DGS are for rare disease tests. DES stands for Diagnostic Exome Sequencing, and you can understand that this is a kind of clinical exome sequencing. It analyzes about 6,000 genes, including mitochondrial DNA. And WES analyzes the whole exome, and DGS is a kind of whole genome sequencing. Genes that related to several rare diseases could be tested through this test. We also have diverse tests for cancer. Risk screen is a preventive screening for the healthy individuals. Genome screen is a preventive screening for individuals with risk. Hereditary cancer panel and women's cancer panel are germline testing for those with family history. HRD, hematology cancer panel, solid tumor panel, and liquid biopsy tests are for the patients who has been already diagnosed with cancer. For solid tumor test and liquid biopsy test, OncoMind knowledge report containing relevant therapies aligning with patients' genomic alterations is provided with the test result. Liquid biopsy test overcomes the limitation of tissue biopsy and thus provide better options for patients and physicians battling cancer. It is recommended to the cancer patients in stage 3 to 4. GCG OncoMind Comprehensive Assay Plus is all-in-one test to discover all the patients and physicians need to know for target therapy and immunotherapy selection. It provides MSI status and tumor mutation burden score also. HRD is an essential test for therapy selection like PARP inhibitors for the ovarian cancer patients. At the last, we also have various genetic tests for the purpose of health checkup. Risk screen analyzes 1 or 2 single nucleotide variants related to the disease. Genome screen analyzes the whole regions of the genes related to the disease. Genome Health screens several single nucleotide variants associated with the disease. And Green Biome is a gut microbiome test which enables us to analyze the ecosystem in examining gut. Besides, we also have pharmacogenomic test and telomere test. Risk screen is recommended to general healthy people for just specific regions, and the price is more affordable than genome screen. On the other hand, since genome screen analyzes the whole regions of the genes, which has high correlation with the likelihood of disease occurrence, it could be recommended to the examinee with a family history of disease. The test method of risk screen is PCR, and genome screen uses next-generation sequencing method. Genome Health also analyzes the disease-related single nucleotide variants, and it can analyze up to 44 to 45 kinds of disease by NGS method. The risk of developing disease is classified into general care, alternative care, and intensive care according to the test results. Green Biome Gut Service is a kind of gut microbiome test. As you may know, Green Biome gut microbiome is related to several diseases. We provide the information about balance of the microbiome of examinee along with disease-related information for 9 diseases, including obesity, diabetes, irritable bowel syndrome, and so on. Telomere analysis of the length of telomere. Telomere is an objective indicator of biological age. By analyzing the length of telomere compared to the group of same age, we provide the biological age and aging rate. It makes the examinee possible to manage the health in a smarter way by checking the aging rate regularly. As for the pharmacogenomics test, it tests for genetic factors related to drug metabolism. It analyzes the compatibility with 34 common drugs that everyone is likely to take at least once in their lifetime. Risk of drug sensitivity, drug resistance, and risk of experiencing adverse reaction to drugs are analyzed based on examinee's genotype. To summarize our strengths, I'd like to say that We have #1 market share in South Korea. We have most diverse NGS panels from rare disease to cancer, and we are indeed the pioneer in launching a clinical genomic diagnostic service. We really wish we can reach out to patients in need in Pakistan. Let's see how we can collaborate. Please feel free to contact us if you have any questions, and thank you all for listening.
Thank you very much, Ms. Jin An of South Korea. Thank you very much for the detailed session. We'll definitely make use of your biological age test for all our actresses out there. Session 13, Next Generation Sequencing and its Applications by Dr. Ozan Asiki, Turkey. So can we have Dr. Ozan Asiki, and he's going to speak about next generation sequencing and its applications.
Hello, everyone.
Hello. We can hear you and
hope
we
you
see
can.
your screen as well.
You can see my screen?
Yes, we can see your screen.
It's good. Okay, let me start. Just a moment, please. My name is Ozan. Ozan Ashic. I'm a biologist. And I was educated in Istanbul University. So I will try to do my best to be fast. Genox, who we are. Genox is a genetic disease center in Turkey and also registered by the Ministry of Health. So I can absolutely say that our job is next generation sequencing. We started the business in 2008 as a research center, but things changed and we started to run the clinical samples in our lab. And our main business is, I can say that, NIPT and also whole exome sequencing. Also, we are having services not just in Turkey, we have services abroad. We are making all steps of our services in our own lab. And for the NIPT, we have more than 1,000 samples per month, approximately. And I can say that we are the dominator of the, Middle East, also Eastern Europe, I guess. And on the other hand, for the waste market, we have performing more than 400 samples per month, which is for clinical part and also the research part. Some customers are needing, FSQ files, and the others, reporting. Also, we have our own clinicians in our lab, so if needed, we can supply a report which is signed by the clinician. So before the services we have, I just want to summarize what is NGS, next generation sequencing. There are several ways to sequence the DNA, like Sanger, but with the NGS, we can pool, we can multiplex the samples, and that's why it makes cost effective to compare the other methodologies. And also it's developing day by day. Applications of NGS, there are lots of applications, of course, from research side, also the clinical side, but we have also research services too, but I would like to talk about the clinical services we have. NIPT, whole genome, whole exome, targeted panels, maybe. RNA is so quite different right now. So I want to talk about a little bit how NGS works. I'm sure you know better than me, but it's nothing to lose, to remind it. First of all, after DNA isolation, we have fragmented DNA. We can use enzymatic ways, also the sonication for fragmented DNA. And then we need to attach unique adapters called indexes for every single sample. So at the end, we have to distinguish all the samples between them. That's why we need to add unique adapters to all fragments we have. After that, in the Illumina way, we are using a chip, which is amplifying. We are using labeled DNAs for amplification called SBS imaging, sequencing by synthesis. And then the last step, data analysis or interpretation. Sorry, I'm gonna pass this one. That's a video. So Genox, we have, I can say that two sub companies, which is called Genox Genetic Disease Center and also Life Science. Life Science is about the research services we have, consumables to regions, also RNA-seq on epigenomic sequencing. And also on the other hand, the main issue is clinical services we have. Sorry. NIPT. It's the main services we have. As I told you, we already more than 1,000 samples per month, and we have so deep experience about the NIPT sequencing, also the database. We are using Illumina Verisec NIPT solution technology, and it's for detecting for aneuploidies of the chromosome aneuploidies. But additionally, with our service, you can find 70 different inserts and deletions like that. So many information you can have with our services. After that, whole exome sequencing. This is theoretically, how can I say, it's a targeted sequencing. All we do is capture the protein coding regions from the DNA using beads, and then amplify the DNA. And at the end, we sequence the DNA and find the SNPs, CMVs, insertions, deletions, what the clinician needs. We are doing all the services in our own lab, and we are using Twist Human Comprehensive Exome Kit. Average depth, I can say the minimum depth is 106 for our services. If needed, we can supply FASTQ files or report services. It's depending on what you need. And as I told you again, we are running more than 400 samples per month. So we have a very deep database in Turkey also. If the clinician didn't find any information about the whole exome sequencing, then whole genome sequencing is another option for diagnosis. Of course, this decision is up to the clinician. In our services, we are using, again, Illumina's kit. The average depth is 30 weeks, but it's possible to have FASTQ, raw data, or also the report services from our lab. So basically, what is the differences between them? For whole exome, we are capturing just 45 megabases of regions. That's all. A little, talking about 1 or 2% of the all DNA. But for whole genome sequencing, we are talking about 3.3 billion bases. No capture. All the DNA is amplifying. So at the end, we have data from whole exome, 8 gigabases. It's an average. Sometimes we are getting much more than this. For the whole genome sequencing, we have 120 gigabases. That means 30x coverage per sample. For the whole exome, it's 100. What about oncology? So we have oncology services too, for hereditary, somatic, and hematologic patients. As you know, for the hereditary cancer patients, we need just blood in the tube is enough. But for solid tumor detecting, we need fresh tissue or FFPA. There are several options for the hereditary cancer services we have, and also for the solid too. And I can say that we are flexible on these points. We are working more than one companies for the oncology testing, but some of services have CE-IVD also, especially for the hematology and also BRCA1 too. And also plus services we have is CE-IVD too also. Genes numbers are different, but I cannot say that for the biggest panel we have, it's using DNA and also rare RNA, so it's possible to see the RNA fusions, and all this process is CE-IVD on the market. Also the ministerial of health. It's possible to find, SMVs, index, CMVs, and also structural variants, including tumor mutation burden, or also MSI. All the tests we are using is depending on the capture and hybridization, except BRCA1 and 2, it's amplicon sequencing based. Coming soon, I guess it's going to be on the end of this year. We have a liquid service too. Hope so. And also Tata, it's a carrier scanning test. This is a service for couples to have, healthy generations before and during the pregnancy. There are, 1 to 3 mixes, 3 panels we have, but most of them is depending on the area, I'm pretty sure, but most of them are in Turkey, SMA, DMD, and also cystic fibrosis. As I said, this is just a carrier scanning testing. So bioinformatics, we have bioinformatics teams very specialized, and if needed, we can supply to our customers from research to from report analysis, including to SMP to on the structural variants. Everything is happening in our own lab and in our own server. So what we have MySeq instruments, NextSeq instruments, and NovaSeq instrument in our lab. As you can see, it's very large volume. You can run lots of samples. As I remember, at least 300 samples you can load to Illumina NovaSeq 6000 instrument for WES, whole exome sequencing, 100 sample per sample, 100 coverage for sample. And also we have other instruments too, Ion Torrent and also MGI, DMBSEQ G400, and also BGI-seq. But we are changing our ways to Illumina nowadays. So why Genox? There are lots of service providers in the world, right? Why you can choose us? We have multiple platforms. So if you have one sample or 100 or 1000, no problem. We have choices for load it. Rapid turnaround time. An example for the NIPD, our report day is 3 or 4 days, maximum 4 days. It's very fast. And also we are guaranteeing to the quality. If something's go wrong, we can rerun, no problem for us. And also we have so much experience about the NGS. At the end, we have certificates. ISO certificates is okay, not easy to have them, but EMQN is compared to others is a little bit harder. We joined EMQN for DNA sequencing and also NIPT, and we, as they say, satisfied about it. I mean, our results are approved by, Quality Lab, European Molecular Lab. And it was fast. Thank you very much for listening to me.
Thank you very much. Thank you, Dr. Ozan from Turkey. And we move on to the next session, welcoming the newest set of guests as well. And the next session. Thank you very much. Okay, so we move to the next session. It's on stem cell technology. We have quite a few stem cell centers in Pakistan working on regenerative medicine. And we're working towards umbilical cord banking and all that as well. So Dr. Sarah from National University of Singapore, thank you for joining us. And can you hear us?
Yes. Can you hear me?
All right. If you could please raise the volume of your system. Dr. Sarah, can you hear us?
Yeah, I can hear you. Can you hear me?
We cannot hear you too clearly. If you could kindly just fix that for us.
Is it better? Hello, is it better?
Yes, it's much better. Thank you.
Right, cool. Well, first of all, thank you for having me today. I would like to talk about what we do in Singapore, where we now weaponizing mesenchymal stem cells by putting genes into these cells to make it very effective for cancer therapy. And just going to go through the technology that we have that help us to engineer these cells very efficiently. First of all, let's take a look at the cell therapy landscape. Overall, we have explored and they are advancement in cell therapy to date for clinical trial, mainly CAR-T, where CAR-T has now advanced to a stage to show its effectiveness in hematological diseases. And nonetheless, CAR-T has faced numerous challenges when it's tried to explore solid tumors. Recently, and unfortunately, Bayer just pulled out their deals with one of the company to use CAR-T for the treatments due to toxicities. And the next cell type that is widely used for clinical trial is actually mesenchymal stem cells. We have seen this field grow significantly. Particularly, we have seen a lot of clinical trials being approved in US, China, and everywhere else to use these cells, not only for regenerative medicine now, but also having this in COVID-19 treatments. So now what we see is that over the years, there are more than 1,000 clinical trials, and all of these trials show that it is safe to administer the stem cells for human, but there's a lack of therapeutic efficacy. And there's an emerging recognitions that these cells could be very useful if we modify it with a therapeutic genes. For example, there's a recent success in SanBio phase 2 trial on traumatic brain injury. And what they do is to actually introduce a modified stem cells that overexpress Notch1, so that the stem cells can have high expressions of certain growth factors to help brain injury. What they find is amazing. They have introduced this in 60 patients, and they found that majority of the patients actually could gain functional advantage, where normally standard treatment will help the patients to improve in a score of 2.5. But having these modified stem cells, they found patients with recovery up to 8.5 to even 10, almost as normal. And this good news is it's now spreading the word. And what we see not only in this trial, but there are a couple of high impact journals now starting to look into how stem cells can be modified for therapeutic purpose, like Science Advances, and all the other reviews have pointed out that you need to modify stem cells. Now, the question is, how do we introduce gene into stem cell efficiently? So currently, there are many ways to do so. And in the clinical trial at the moment, majority of the clinical trial are using virus to introduce. And we all know that virus have an issue of scalability. It's very expensive. If you need to make a virus, it's at least $2 million in Singapore here, and as well as the safety concern and regulatory hurdle preventing this from growing fast. And this is efficient. On the other hand, we have a group of other systems that's non-viral, including chemical, electroporations, and etc. Unfortunately, these are either inefficient or they are very toxic. So what we do in our work is to actually discover a way, a reagents chemical base to help to improve and enhance the polymer-based transfection. What you see here is in human mesenchymal stem cell, where we introduce a genes that carry a GFP reporter. What we see is with lentivirus modified, you do see high number of cells being modified, but none of this, if you look at the GFP expressions, they are very lowly expressed. And if you were to use just the polymer methods, as what we found with others, the transfection efficiency is low and expressions is low. What we do is actually develop a reagent, we call it an enhancer, that helps the transfections using polymer. And over here, you can see that almost all the cells were modified at high efficiency and high expressions. And actually this helped us to overcome a couple of hurdles, including not to use virus, lower developmental costs, and now the cells become more potent because it carry more expressions of the therapeutic genes. And it's not magic. It's based on a mechanism that was discovered in 2017, where we realized that the problem of low efficiency with polymer-based methods is not the uptake. Actually, in all the cell type, DNA complex get into the cells very efficiently. The problem comes with when they are inside the cells, they were being routed to an acidic compartment. When they then get degraded. And what we do is to actually have the reagent 1 and 2, we call it enhancer, where it's a combinations of fusogenic lipids that help to route the DNA complex out of the acidic compartments and then put them on a microtubular network by stabilizing this microtubular pathway with a HDAC6 inhibitor. We can actually help the DNA complex to get into the nucleus for high efficient expressions. And that's how we overcome the issues. And since then, we have actually tested this method on different sources of mesenchymal stem cells, and including allogenic bone marrow as well as umbilical cord derived stem cells. And you can see that this is agnostic to any of them and allow us to modify different type of mesenchymal stem cells at high efficiency. Now, the next step is to what do we do with this highly modified stem cells? Currently, we are looking into using them as a vehicle to deliver therapeutic gene for cancer therapy. We are looking into how we can use this to help patients with solid tumor, which is 80% of the cancer instead of, and they are currently have no help because they have less than 10% response rate with CAR T therapy. And allow me to just briefly walk through what is the mechanism behind. So what we do is to actually put the genes called cytosine DMA, the aminase is an enzyme into the cells, the mesenchymal stem cells. And this stem cells has a innate property to home or nest onto the tumor cell. And now it can serve as a vehicle to put these genes, the cytosine deaminase gene, close to the tumor. And then we'll introduce the patients with a prodrug, which is non-toxic to oral. It's called 5,4-cytosine. And when this prodrug comes near to the stem cells, the enzyme will then convert the prodrug to a toxic drug called 5,4-uracil. It's a very old drug and it actually targets solid tumor very efficiently, but this drug is very toxic. So by having stem cells to localize conversions of this prodrug, we managed to reduce systemic toxicity. And what you see here is exactly what it means. With the mouse study, we found that using 5FC and these methods, the mice weight and do not change and there's no side effects. Whereas if we were to introduce 5,4-uracil directly, you can see the severe side effect this mouse is experiencing. And what we see is more than just using 5FU to kill the cells. I will talk about it later, but it actually activates a C-gasting pathway, a pathway that's recently being discovered that will help to release interferon beta, and this cytokine then can activate immune cells, resulting in anti-cancer immunity. Right. So this is what we have done over the years, where we first look into the safety itself. In terms of mice, we have actually looked into how these cells can be introduced to the mice, and in 1 and 3 months, it actually do not cause tumor and do not disrupt the tissue in the mice. And at the same time, we have also looked into how these stem cells can be used in a canine patients. I'll talk about it later. And not only us found that this is safe to use, but there are also other clinical, preclinical studies, lots of publications that show that using mesenchymal stem cell for cancer therapy is safe. And there are 3 completed human trials in US that have shown that it's safe to use this method. And what we see also that it can effectively reduce the tumor size and suppress it for a long time. Using 1 dose, you already see a drastic reductions in the tumor. And this is actually a glioblastoma resistant cell line. control versus treatments, and we could see suppressed tumor growth. If we were to use multiple doses, the result is even better. We can actually suppress the tumor growth up to 1 month. And in some cases, we do not even couldn't even locate the tumor anymore. We have gone one step further to look into how we can help canine patients with naturally occurring cancer. It's a busy slide. I'm going to go through case by case. We have helped patients with recurrent cancers, whereby this dog patient has recurrent sarcoma. After 3 times surgery, it has actually developed ulcers, that wound that do not heal. And after we provide 3 doses of treatment, the wound healed. And we're happy to share that in 32 months, this patient has been cancer-free. And recently, we just got a call from the owner to say that this patient has passed away, but died of frailty. And another case here is similarly, it has a recurrent tumor from chemotherapy and surgery. And what we do is to actually introduce this stem cells post-resection. And now actually it's already 20 months, these patients remain cancer-free. These are other cases that shows a good response where the tumor is gone, the fur came back, and the wound healed. And this is direct injections into the tumor itself. You can see that such huge tumor can actually be hot. The growth is hot, and the tumor can be removed significantly. In addition to direct introductions of these cells to the tumor, we have also introduced the cells through intravenous methods. And this patient has metastatic lung cancer. You can actually see that over time, the cancer remains static. It's already 25 months, and these patients have good quality of life with no coughing post-treatment. Just like to go into another case that we have is a compassionate use this time. We actually tech transfer our technology to a GMP facility in Indonesia to help these patients with clear cell carcinoma. This before treatments, and this is after treatment. We can see a collapse of the tumor, and very happy to see this message from the clinicians in Indonesia that it has helped the patients by actually reducing the pain. Before treatment, VAS is 7 to 8. After an area around the wound is softened, and there's no more pain with these patients post-treatment. And we have also seen, just like the canine patients, it does not introduce severe side effects to this patient. I'm going to end soon. Just like to add that we are currently translating this technology to a large scale, where we could actually create off-the-shelf ready product. And this means that we can modify the cells at high efficiency in a large scale. We can generate 1 billion cells in a 1 week turnaround time. Then we can actually stock these cells into vials, cryopreserved vials, where we can then work with our collaborator overseas and share these vials with them. We are currently tech transfer this into a GMP facility in Singapore, which allow us to fulfill that criteria to send the cells to other area. Just like to add that in addition to product therapy, we are also doing more developments to do in chemoimmunotherapy, whereby we can actually now help to induce anti-cancer immunity by having additional gene, interferon beta, into the colon clone. In the in vitro study, we find that having interferon beta, it kills the cancer cell much more efficiently. And we see a long-term effect in the mice where after 2 months post-treatment, we see the tumor could be suppressed in the long term. And we are starting to also move into clinical trial, working with local clinicians in Singapore to see how we can use it for glioblastoma treatment. What you see here, the green color are actually mesenchymal stem cells that like to home. And you can see that they attach themselves onto the tumor bulk here very efficiently. And it can kill and wipe out this tumor bulk at high response, whereas this tumor has already resistant to the only chemotherapy drug that is available for glioblastoma, temozolomide. And we are also working with our colleague in Singapore General Hospital to use it for colorectal as well as sarcoma. Again, what we see here is that these are tumor, and this is MSC. You can see that over time, 4 hours after injection, MSC is everywhere, but over time it actually gravitate towards the tumor, and it can stay up to 10 days to produce the toxic drug. We see a good
Sarah, could I request, I hate to interrupt you, but I request you to sum it up now. We're at the end of the session, please.
Okay, this is the last one. We are also working with Dr. Ahmad and Dr. Asmat from TCP to explore the use of it in Pakistan. Thank you.
Thank you very much. Thank you, Dr. Sarah. That brings us to an end of all the speakers. Thank you so much, all of you, for joining us, all the speakers. But now we move to a panel discussion. And for the panel discussion, I would like to request the panel to be on that chair, on that table right there. And the rest of you can move towards other seating arrangement. And the panel would comprise of Dr. Shazad, Dr. Ghazna, Dr. Fahad, Mr. Awais, Mr. Asmat, and Mr. Amir Hashmi. So if the panel can come together on one platform, and I'd like to request our rest of them to move elsewhere. If you could over here make some space for the lawyers as well, and everybody else who has joined us. Dr. Ghazna or Dr. Shazad, Dr. Fahad, Mr. Asmat or Mr. Amir Hashmi. Should we start the panel discussion and then when he comes, he can join in? Mr. West, should we start the panel discussion and then when he comes, he can join in as well? I think that's a better option. Right, so let us initiate the panel discussion, and the discussion does, revolve around next generation healthcare using imaging, genome, genetics, as well as AI and all that we've been talking about today, and how all this effort of Dynamic Medical Group and everybody else involved and HSA is to bring all of this to Pakistan for the betterment of Pakistan. Let us start with Dr. Shazad. Thank you.
Thank you. As I mentioned this morning, when you were having this.
Can you bring it a little closer to me?
Welcome note when I was talking about that. There is a huge research and investment by the use of technology. The different cost may be high, but that can be dealt with when we have partnership mode. So the best way to proceed further is a public-private partnership model. Public-private partnership model where the private sector brings in the technology, international and national. The public sector institutes become partners with the private sector, like we should be leading the training, the capacity building, and hands-on the machines. We should be leading for the advocacy, the policymakers area, bureaucracy, and political teams. We should be facilitating the private sector in bringing in new technologies and making them comfortable when it comes to use by the public. So the government alone will never do it definitely, and we do not have the capacity as well. So there is an issue of capacity as well as willpower, as well as a lot of priority. But the way you have seen the presentation of you and had idea of various aspects which was shared. So and then being a public health professional and
traveling around the world, I have seen many countries, not few, many countries are using latest technologies, next generation genomics. There are institutes across the world who have taken lead into this. We are actually, we are more needy than these countries which we listen to. They have very limited population. So Singapore is a very small country. Turkey has less population than Pakistan. Germany, all the European countries, even Finland, I think, less than a billion. So this is something which is very tricky. That we have such a huge problem. Huge proportion of Pakistan population is having non-communicable diseases, cancer, heart diseases, genetic disorders. Yesterday, there was somebody from Amro, the region in which Pakistan is situated. And they were astonished to know that only Pakistan has this huge burden of thalassemia. No other country of Amro region has thalassemia. I don't know why, but this was new to me as well. The Amro office of the WHO told me that Pakistan has the highest burden of thalassemia, and the rest 21 countries do not have that. We are neighbors. We are like in one zone. Other countries, Iran, Afghanistan, Yemen. These are all almost the same.
Yes.
All of them are Muslim countries. There is something we didn't do. That is why when they did something, pre-medical screening or whatever you can do. So thalassemia is preventable if we have this bit of proactive approach. Similarly, for all the genetic disorders.
Exactly. Dr.
There
Kalsa,
is one which is for prevention and there is one for treatment. So when we met Asmat, and I'll hand it over to Asmat now and Ratna, when we discussed this, they told me about a lot of technology innovation which have happened for more than a decade now. And none of us in Pakistan, and by us means the literate one, the intellectual one, even if they haven't heard about this, how come a normal doctor or routine medical officer or routine health worker knows it? So that is one problem statement from my side. We should be talking about solutions, but what can be done, how to proceed further, we should not stop. This conference should be, I always again say this should be the starting point. We should not think of getting all the answers today. Even if we get more questions,
yes. So, Dr. Hasna and Mr. Asmat, could you tell us about this infrastructure that's going to be set up here, the machinery, the equipment, and all that is going to be offering, which is not actually available right now to the Pakistani public?
So, thank you. And so this is a tremendous opportunity for Pakistan. And the equipment, so I'll be really, so everybody can understand, I'll be very basic in my description. The equipment available will be housed in health services and packing. It is a reference laboratory and it's going to be commercially available, so exercise. So people that need blood tests, for example, the BRCA1, BRCA2, which is a breast cancer gene. Normally, if you go to X laboratory, it costs approximately $1,000, $1,500, and they send it outside for one test. If we do it locally in-house, it's going to be much cheaper, it's going to bring down the cost, and we will then have the data. As Dr. Shazad said, this is a two-edged probe. The two double-edged opportunity for us. One, to get data, which is also the new oil, data for our population. And secondly, we will also drive a commercial entity. So that is the opportunity to be put for our people. And it's not just when you have disease. The other thing that we can have is the genome on a chip. We used to think it was sci-fi and we didn't know how to do it, but we can have our genome on a chip, and that genome on a chip will, on a USB, will then tell us, give us the information, what kind of diseases we are predestined to have. And so we can do dietary modification, exercise, take relevant medication to stop them happening before them. So I'll stop there and I'll pass it on to my learning colleague. Thank you so much.
आपका काम नहीं कर रहा या थोड़ा सा करीब कर लीजिए प्लीज।
जेनेटिक के हवाले से मैं बात करूँगा। जो हमारे आजकल जो हम यहाँ के सेंटर जा रहे हैं आउटसाइड कंट्री, मिलियंस ऑफ डॉलर्स खर्च हो रहे हैं। जब यहाँ में फ्यूचर और प्रेडिक्स जो हम इसको ट्रांसफर कर रहे हैं तो वहाँ के लाइक रेट्स ऑफ आवर सेंटर्स नहीं होते। लाइक अगर एक सेंटर्स की यहाँ के हम दो दूसरे करें उसको यहाँ $50 का खर्चा या $100 का खर्चा आएगा अगर लाइक हम उसको बाहर लाइक बेचते $2,000 और मोर देन $500 नहीं वहाँ से कमा दे रहे हैं। उससे हमारे यहाँ से हमारे स्केल भी हैं, हम यहाँ पे एस्टेब्लिश भी कर सकते हैं, ट्रेनिंग का भी इशू भी है, हम बाहर पूरी तरह कि हम पाकिस्तान की इंडस्ट्री तो ये एक बर्डन जो है जो पब्लिक एक्सचेकर के हम बार जो है ना हम मेडिसिन परचेज कर रहे हैं, गवर्नमेंट जो है परचेज कर रहे हैं और उसके रेजिस्टेंस भी है, कुछ पता नहीं है, जनरेशन के रिलेशन भी है, बहुत सारे चीज तो अगर हम बात करें तो रिलेटेड केस में जाए तो हम साइज होता है कि ड्रग्स अगर हम करें तो हम साइज होता है कि स्पेसिफिक देखिए हमारे जो पेशेंट की जो पॉकेट की जो खर्चा है टारगेट मेडिसिन का जो है वो भी ऑलमोस्ट 70% मिनिमाइज कर सकते हैं। और कम्युनिटी में लाइक अगर हम स्क्रीनिंग टेस्ट कर लें तो आपके पास टेस्ट आ जाएगा कि मेडिसिन जो है उसको मोबाइल में होगी वो जाके से और वही मेडिसिन से होगी और तो जेनेटिक्स के हवाले से हम कर सकते हैं अगर हमें गवर्नमेंट भी सपोर्ट दे रही है इसमें टैक्स में और इम्पोर्ट में अगर थोड़ा बहुत सपोर्ट दे तो हम स्टेब्लिश कर सकते हैं क्योंकि हमारे पार्टनर है वो और यहाँ पे फिर हमारी जो राजस्थान के लिए हम यहाँ की एजुकेशन में पार्टिसिपेशन करें बजट से बेहतर जिस तरह की बातें कर रहे हैं तो हम जो है ना हमारी एक्सपोर्ट भी बन जाएगी और हमारी रेवेन्यू भी जो है बाहर से रेवेन्यू भी जनरेट हो जाएगी और दुनिया में इसकी कंपटीशन भी है। मैं रिसेंटली में ट्रांसफर किया था कि कैलकुलेटेड रो मार्क है तो अगर आप इसके इशू शुरू करें तो कंपनी भी फायदा है और स्पेशल को भी
मेडिकल टूरिज्म को भी ये प्रमोट करेगा।
मेडिकल टूरिज्म के लिए बहुत फायदा है क्योंकि अगर आप कोई चीज पढ़ रही है तो आपको बेच रहे हैं
बिल्कुल। और आप मिस्टर अगर साहब थोड़ा सा बताएंगे ये जो डेटा है हाउ इज दिस डेटा गोइंग टू bring us revenue as well that like Dr. Razda was mentioning because this data is very important and people need it for R&D repeatedly मतलब हमारे patients और end user के लिए तो चलो अच्छा है overall तो अच्छा है ही ये revenue building के लिए other than medical tourism and other than the patient generated income how is this data and R&D how can we actually sell it abroad or something so that they can use it to develop trends and understand epidemiology and everything else as well.
Usually this just the content of the conference speaks itself. The lady in Singapore just mentioned that there were 1,000 clinical tests. There's a 300,000 launcher-based country. We have a 258 the power girls of the world. Name this 250 million as a reference point, not just because of the love of mountains or the Himalayas and this, it's just about the population and the carry we carry over there. So if we connect that data in regards to this company, our shop to be the company, something here, 2015, they said, and within the 7 years, it's a $500 million company. फाइन बॉम्ब यहाँ पे हमारे $500 million बनते हैं बॉन्ड बेच के
A big hand for AirDoc and thank you AirDoc for coming over today and demonstrating your skills and everything that you've developed.
Coming back to the question, that the data as what Snots said in the start of the video, how we can This quality and what our first officer action speaks louder than the word. The data itself is our intellectual property, but it's all up to how we use it. We build $2 billion for plants of motorway, but there were 3 district headquarters in the Sakhalin area. It does not have any ancient technology of which it's really can.
We welcome, yes, we welcome our Honorable Chairman, Special Technology Zones Authority, Mr. Amir Hashmi. Thank you, Mr. Amir Hashmi, for joining us. And we are having this discussion about next generation healthcare technology. Dynamic Medical Group and HSA Health Services Academy has brought together this medical conference. We had speakers everywhere from Germany, from Finland, from Korea, all over, and they spoke about almost everything from genomes and genetics to stem cell, regenerative medicine, and everything else. And we were just having a panel discussion in which Dr. Rasna and Mr. Asmat and Dr. Shazad, as well as Mr. Aves, were discussing how important this genetic research lab that's going to be set up in HSA is going to be, not just to give the end user all those tests that used to be actually tested abroad and used to be heavy on the pocket, and they wouldn't even be as genuine or as relevant because of the transportation issues. So now they'll have it right here, and the revenue it's going to bring us in terms of medical tourism, and as well as all the data that we're going to have, having a huge population, and how we can use that data for artificial intelligence, for R&D, and for actually giving it abroad and selling it and bringing revenue. So we would like you to join in the discussion and give your 2 cents about it. I'm Dr. Tahira.
Okay, so to tell what I was referring, so we built a concept, which a friend of mine has made it with a $2.5 billion. And I was telling you that the PhD, the DCO, Sakha was telling you that they have 4 district headquarters, in which 2 of them do not have a basic scan or MRI machine. So what the scheme is, and that's right from the value chain, the technology, tech, which is we can drive out of this 250 million people. It's great actually 250 million. It's no more.
Yeah. But we needed the motorway to get to the CT scan as well. So that's all that we have to say.
That's really coming in that this data itself is our sellable commodity. If we provide it and we keep it in a proper way.
Definitely. So can I have Mr. Amir Hashmi share his thoughts as well? आप थोड़ा सा अपना करीब कर लीजिएगा माइक प्लीज, आपकी आवाज नहीं आ रही बिल्कुल भी.
Bismillahirrahmanirrahim. Assalamu alaikum. Esteemed, I assume you have a lot of doctors, so I'll refer to the doctors. Of course, since a childhood, we had many doctors in the family, and it was a cliche in the family. Probably the most noblest professions. You have the well-beings of all of humanity in your hands. So. All the services that you provide, and of course in Pakistan, we have globally renowned doctors all over the world and in the country. But I think from a technology perspective, and why I'm here is we view technology as a horizontal sector, not a vertical sector. And when we look at your industry, we look at with the view of health tech, biotech, and medtech. And of course, it's very new to Pakistan. We've done a lot of research. But I'm here to provide full support from the federal government in our capacity as an authority that will help you with not just the enabling environment, but some of the issues you just referred to, Dr. Dara, in terms of the equipment
that's required. Pakistan में ड्यूटी बहुत होती है for high-end equipment, particularly medical equipment, and then we don't have technology transfer, and there's a lot of issues in legislation, and not just the federal level but the provincial level. So here, the government's come up with a solution that we feel will see at least jumpstart not just your industry but all technology fields in the country. And so I'll walk you through a bit of why STA was formed and how it will relate to your industry and how you can benefit, particularly the geographical area that you're sitting in right now in NIH. And you mentioned, Dr. Zara, a lab. Is the lab physically to be in NIH?
It's here, it's in HSC, in Health Services Academy.
Where?
Here, this is the way you're sitting right now. Jahan baithe hain, bilkul. It's the facility mein hogi lab, which will be testing all those tests that are currently being, sent out to the UK or the US, and they are costing the patient like almost 1 lakh to 2 lakh rupees. So वो सारा कुछ जो है और up to 5 lakhs भी होते हैं बहुत सारे क्योंकि हमारे पास genetic lab किसी किस्म की भी पाकिस्तान में इस वक्त available नहीं. So then the same test would be available at a rate of I think 30,000, and I think Mr. Abbas would be able to quote those numbers and rates much better than I would. Mr. Abbas?
Yeah, so this is an excellent location because you're right next to the next one.
Yeah.
So I'll explain how you can fast track this to get a license. BCM. If you can just go back to the slide again. Next. Go back to the why I use this as the first slide and why I had to use it to the cabinet members and the Senate and the National Assembly is हमारे passport पे लिखा हुआ है Islamic Republic of Pakistan. So of course, I've spent most of my career overseas, but I've been back in my own country for 18 years. This word, Islamic Republic, and not because we differentiate ourselves from global humanity, because Allah, Sari, Dunya Allah ki creation, and we cannot isolate Pakistan. Although they jo ilm pe focus kar, and of course in Spain we saw it about century onward. And we did wonderful things as but we moved away from knowledge. Or it's not knowledge is coming better, but we see even half of doctors over here, at least half. So the three-fourths. So the average age, I'm just looking around, even if you're in your 35, 40, there's 500 man hours, I would say, or years of knowledge in this room. But doctor का knowledge होता है, they lead the people. So why did this help the economy of that? This is the question that's been bothering me for many decades and many years. Dr. Bandeme, people are here, not always required, but other people together. So when you really study, and the Prime Minister asked him, how do we create knowledge? It's a word. So how do you actually create knowledge? How does the federal government pay? So we studied the leading knowledge right now, which is in the city of Shenzhen. Korea skyrocketed. Abbas, me and I met through because he had brought in a very large Chinese company. I forgot the name. That is willing to transfer technology to the medical sector. Right? And that's how I really appreciated Abbas's drive and passion of bringing the Chinese in. This is a $1 billion group that he was able to bring in, and we've been working on it for several years. So, my own conclusion at the federal cabinet was to create an authority. And where technology is given from the technology, and Hamza, make sure you share the active part of it with everyone in the group.
Sure, sir.
So it's 18 pages. It's probably one of the best documents written because there was a lot of professionals around the world that gave it to it. So we took examples of Korea, we took examples of course, Europe, we took examples of China, because China has over 3,000 tech clusters. Economy का 3 trillion पे पहुंचती है, ऐसे नहीं पहुंचती, right? वो जो 1.6 billion लोग 3 decades में 850 out of poverty, Did they follow something in the Quran? Of course. They followed exactly what the Quran says about poverty alleviation. So the foundation is, if we want the economy to grow, then we have to have knowledge. And now technology is a vertical. Hence, the Prime Minister himself became the president of the board of HealthCare. And of course, we have some of the leading technologists globally on the board, have the relevant federal minister of finance is also important about that we have funding. So the key ministers in place. Next slide. And I think probably because you guys have so much knowledge yourself, you probably know this, but skip this. It just shows where in the world go back. This is important to show how knowledge of the go back. On this slide. Yeah. So if you look from, of course, we won't go back right to 1785, but if you look at 1990, 2020, up to exponential knowledge creation, and in your field, because again, those four doctors and family medical doctors and और नंबर टू मेन ये होती है कि पाकिस्तान में medical researchers को hiring facility. So we made a platform and we're going to give you full support from SDK because the base has been, mashallah, I think although I think अगर ये बढ़ता रहे इसने जो federal government ने इसने drive करी है, he convinced everyone where it actually ended up on my desk to make medical clusters. And understand how that will help you in an application to allow you to become a medtech, biotech, or health tech cluster. And of course, all of these, if you look at the technologies, many are applicable in your medtech sector. Next slide. I don't think the doctors again after globally will travel to India. Dunya mein, most of the economies have taken full advantage of this law that we made just in Pakistan, those of 2021. So cabinet mein, I was asked, being a professional, it means these trials again, India and those are issues that I think I said legislators laugh on medicine. So then they were on the back foot to help get this to the parliament, right? I said it was your job, not mine. I'm a professional who's coming to explain. I've worked with these. But when you do the deep study, which the Prime Minister asked for, what did they do to the human capital, the technology transfer, even FDI? When you had different legislation, so you can't reform the whole country, Pakistan is just too complex. But when we take a section of the NIH is showing up to the NIH 1960. And your whole land we are up over 1960 में सीधे ने आप लोग को दिया and 2021 में ये 500 एकड़ खाली है one is called Samvad 61 years they in so in the prime land of the heart of Pakistan in 3 months we had $600 million when we offered the land. They showed us that land is not right. 61 years soil है, बिल्कुल नहीं value. जैसे अच्छा काम करो पाकिस्तान में, फिर लोगों के antennas खुल जाते हैं. So we are very strange. ये आप लोग दूसरा psychologically भी medical science में पढ़े. What's wrong with our psychologically? This should be a special sector. Why when something positive we have to make it negative? So special thing for you guys.
Yeah, our genetics is going to find that out as well.
तो हर अच्छी चीज को आपने तो दुनिया में हमने एग्जांपल दिया और अपने सेनेट को समझाया, एमएनएस को समझाया, कमिटीज बनी, and then they checked it results. So although the government changed, because the one done was when Rama was the prime minister, the current prime minister fully supports all the political parties. So you get full support from the federal government, and we have empirical evidence that will show you where tech clusters in health sciences have skyrocketed the R&D and health services for that nation. Next one. This is just examples. In fact, yeah, Hamza, make sure you give them to Dr. You can share with them. Next. Triple helix, you guys will get very quickly because you guys are, of course, intellectuals. We haven't developed the academic, government, and industry triple helix. So for you, I think you can champion it. Government say, one window, one facility, right now is sitting as the VC, you're the academia, and then industry is where Aways comes in. I think Aways won't deliver itself you saw, but there's many Aways who bring in as CEOs in the panel. If you get that working here, then you don't have to worry about funding. Legislation after building. Next slide. This just gives an example of why knowledge clusters grew. And I'm forgetting the city. When I referred to over 1,000 years ago, Spain, Cordoba city, actual knowledge, knowledge cluster, knowledge cluster level. Those guys are design up, making looks like one of those textbooks. I have it in one of my presentations. So this is nothing new. You cannot reinventing doing more. Knowledge is existence that Allah has created the world. It has, of course, grown in societies where they have respected knowledge. Pakistan mein coaching named one. I remember a Bengali professor, or VIP 9, Dhaka mein professor degree. Alright. So I was really, and I shared that with our federal government. They can't even ask the administrative. Right? So they didn't like my comment. I was advising us to that. Next slide. Ye मैंने outline करा no media because this is probably the most advanced. Just look at the numbers. Just Beijing's GDP, and why I'll share a bit of economics with you guys as doctors, is because the driver for the federal government, because Pakistan's economy is suffering, and Dr. Tariq, you have to champion this, clusters have exponentially grown in GDPs of any nation that is part of it. Pakistan didn't make any clusters, right? CPAR is only 20 years old, and it's producing $400 million in revenue. Just tonight, Pakistan ki abhi GDP 350. So 22,000 companies every year, 29,000. Next slide.
Yes, sir, sorry, to add on what you were saying, is how much too much relevance of it. We're coming here, gentlemen, all the way from China. We're not. The CEO of the company was telling the story yesterday. The CEO was trying to install his one of the related got agent state cancer like this. So we tried to develop artificial intelligence and making this AI just 2050. He developed. And in 7 years' time, it's a $500 million company. It's a PhD, what you were saying.
This one, he's here, right here. Mr. Ryan, would you raise your hand so that he can
China has been a phenomenal story because I've gone during the last 10 years about 50 times. So I was a Western product and I could learn what China did, right? So we'll come to China exceptional.
And he has a wonderful device with him, and if you just show his.
What they've done in world history.
Thank you, Mr.
850 out of poverty, the subsidies success is poverty alleviation. President Xi 2 years ago said to 400 million who are still in poverty in the rural sector. He made a committee under him with 3,000 PhD ke inko poverty se nikalo. Never go to Quran. Anyways, coming back to the textuals. So we keep talking Pakistan. Everyone know what a unicorn is? A unicorn is a company that's valued at $1 billion. Pakistan, you नहीं बना सकते. क्योंकि हमारी legislation, हमारी enabling environment, हमारी रेगुलेट दुनिया में सबसे ज़्यादा हो गई है. To even open up a company space to the Pakistan. So we're going to make attempts. It won't be easy for SDJ because we face music every day. We're a government authority that's customer oriented. Imagine a Pakistani government federal authority जो customer service oriented. What's an oxymoron? So ये जो बनी है ये सारी tech zones में. You can't build magically without the government support. You just can't. Hasn't happened in the world. Next slide. This is very important, right? And I want you all to look inside, and you know you work, all of you have probably worked with these companies. IBM, Samsung, Oracle. When we talk about the economy and why I have to bring the economy into it, because one of my mandates is to help the zones build the GDP of the country. That's why I know yours is medical, but you have to also pull in the economy out of it. All our revenue, ladies and gentlemen, have been outside. So we've been paying Oracle, we've been paying IBM. तो ये डॉलर्स की बात हम क्यों हैं डॉलर्स के लिए 40 सालों से ये कंपनीज are banking and they've been paying for their products and services. Never have you called one and said, would you like to open an R&D center here? When I did, they said, this is the first time we're getting a call from the Prime Minister's office. And who did I call? Take a wild guess out of those.
Roche, did you call it?
Yes, you got it right. G. G के president को मैंने फोन करा because G हमको locomotive बेचना है, health equipment बेचना है, power plant. So I know that we had spent about $25 billion buying. So we've helped G as a company. Definitely. He was so excited because if you give us land and engineers, we'll open up an innovation lab. What's that do for us? There's only 10 of them in the world. They are $1 billion. Technology of transfer, ease of doing business, FDI, job creation, right? So the global spend of this gave the higher. The next one, there it is. So global R&D spending, or what I just showed you, is $2.4 trillion. Imagine if we could even just capture 0.1. But health sector में आप सोचें, अब मैंने लिखा हुआ है yes बार-बार तारीफें करते हैं पाकिस्तानी डॉक्टर्स की पाकिस्तानी डॉक्टर्स के लिए हम एक टेक जोन क्यों नहीं बना रहे वर्ल्ड क्लास चाइना के दोस्त हेल्प करेंगे अमेरिकन very friendly but they will ask for one thing anything so we are targeting to capture some of that. Next slide. Next. So I told you the act was made, so we're very new, we're moving at lightning speeds. We're about 60 people that are all professionals. So when you meet us, in fact, visit us, we don't look like a government at all. We're fully government there. Our touch and feel is of a corporate president of the board. So we are the architect and the regulator of the technology ecosystem. We show you how many we've already opened. Next slide. I think I've already talked about this. Next slide. This is your team, and this is applicable for your field, right? So how do we gauge SDK? So the KPIs, and the government was surprised when I told them, we will give you performance indicator. They didn't ask for them. आधारे बनते जाते हैं बार बार. तो मैंने कहा हमारी performance इंस्टेंट technology transfer technology. When capital development technique, innovation entrepreneurship, job creation, FDI, but local as well. Remember, don't keep asking for money from local contacts until you don't secure domestic investment. Why? That gives you the confidence. So we brought in one of the biggest groups in Pakistan. You've heard of Kia Motors? Yeah. They were by a group called Lucky, Taba family. So they're one of the richest. They took a leap of faith, they've come into tech, they brought, when they invested $150 million, another group from the US put in $300 million to build 4 zones in Pakistan. Because it gave them confidence in local government. So, वो भी हम SPC में आपको help करेंगे जब आपको connection the networking चाहिए हमारे पास एक list होगी कि मुझे these are the companies that want to invest in health tech, med tech or biotech. R&D, of course, that comes naturally to Cuba, and then we export it into subject. Now, so I'm going to share some scary numbers with you. You probably hear chocolate green, and now you hear Minta, now you hear So, my Pakistan officer was Musharraf days. Economy was doing well. We did $25.5 billion. Those are saaf ki baat hai as export. Can you believe the next 5 years, our exports dropped. We were the only country in the world. We won't tell that very well. We went down to 90. So the global economy was growing after the 2008 recession. If you look at our numbers, Ministry of Finance providing, right? We wrong. How can the global economy be growing, your population growing, your industry growing, and your export dropping? So there was something wrong, right? So you can't, until you don't create the enabling environment and say Pakistan may be a product to be a big one. How many ऐसी चीज भी नहीं बना? ये भी I'm sure Chinese will. So the comment I made when this was approved, I said we have to move on technology as a war for and finally all the next stages. So with your, I think, support from the medical community, will introduce you to our entire, not just Pakistan, but global contact. Your quick scheme would be to apply adjacent to this and say we want to declare this center. And our requirements at 200,000 square feet for 5 acres. Either or. Well, there you go, right? So Dr. Amir, let me go ahead. Oh, it's not with you guys? So just for Professor Sultan, you are moving with good speed. Right? He's with you. So after the apply so that once you get it done, you get a ZE license. Next slide, I can pick up. Next, ये आपको zone developer license मिलेगा. उसमें financial incentives होते हैं और साथ network आपको. You not only will be able to bring in companies, but you'll be able to develop your facilities with global or domestic. So my point of contact, Hamza,
yes, sir.
आपका यहाँ कौन point of contact है?
Sir, Mohi Saab.
So इनका visit करा देना for how to do the application.
Sure.
So will you help you with the application? Okay. Perfect. Next slide. ये आपको हम एक्ट में सारे जो लिखे हैं. So this really helps. 10-year tax holiday. You imagine bringing in UP people. तो टेक्नोलॉजी हमारे बच्चे क्यों नहीं सीख रहे? ट्रेन क्यों होते? लैब में क्यों बाय करना? क्या को सीखिए आप आ सकते. But we need a license. You need a license for that. Because outside there again, people use a good incentive. So that's why the license. Like आप पूरी Pakistan को क्यों नहीं सारे incentive देते? फिर imagine क्या होगा? You saw it. So excellent incentives. This I'll let you read in detail when we present it. Hamza will give you the document. Excellent. One window. So we will take your pain away. What does that mean? SDTP, FBR, State Bank, transfer funds. So we've designed a one window, it's halfway through again. You'll come to SDDA when you're licensed and we'll solve your problem. Right? Next slide. Yeah, that's what the target was. Our framework, so we have 3 models. Development of zones, either they can be on yours as public land, but private land is also allowed. So we have applications from private sector. Then existing infrastructure, just building में हम SCDA office है, और ये अच्छी 15 साल लगे structured way खड़ा होता था, सारे dynamic पे देख पाएगा. Finally बन गई. जैसी बनी, we said we want space. So it's stabilized building, it's beautiful looking building. That's declared a tech zone. A lot of tech companies about the one space here and they're moving in. And then clusters. What is a cluster? You're an example of a cluster. So you're already at an age. You have academic activities happening, you have medical activities happening, you have R&D facilities happening, you have investment coming. So you can be declared a cluster. Comsats area, यहाँ अगर इस 5 kilometers में अगर जगह देखें, there's 9 R&D institutes, the site itself, and university, which is Comsat University itself, right? So this is actually a knowledge cluster for all data actually. When you get a license, then you'll see what happens, because that is already there. Next slide. Next. I think we can skip this. Next. Go back. ये आपके साथ है. So of course, thank you for NIH giving the land. But again, like I told you, 61 years पे खाली पड़ा होता economic activity, state land है, Pakistan का land है. तो तो master plan बन गया है, CDA की I think board का approval भी हो गया है, has to be presented to the Prime Minister. Selection of contractors. Yes, we do still have to use PEPRA rules. We are a government authority, so PEPRA is slow, but we're moving as fast as we can. So inshallah, I think in about a month or two, leveling शुरू हो गई है, but proper structure blueprint है जो master plan बना है. I don't think it's here. So the design, you'll be very, very happy. NESPAC local consultants but a company named HealthCare to world-class zones, aesthetics being important. And why? Why aesthetics important? When you have youth involved, youth go and decide to go below 35 here, our discussion, because that's 145 million kids. So they need, at my age, I don't need to see fancy things, they can. But those guys need beautiful structure, they need cafes, they need an environment they can play tennis, table tennis, football. So allow them to grow innovatively. Hence, these zones have attracted the best minds. The way internet cities, some of you have probably seen. It's not just the salary. Everything is not just about money. It's the environment he or she works in. So the design of this is beautiful. You should be able to walk into it and think you're in a world-class facility. So I think I'll end there because I've been talking. I don't know if that takes about 10 minutes, but I think you guys get the gist. Next step to you, I'll work with Dr. on how your application should be done. The scope of what you want to do in medical, that is up to you, but it has to be tech related. Normal surgeries, you can't get a license for. So the tech part is where you get a license. So with that, I think I'll conclude because I've spoken a little longer than the time you've given me. But thank you for inviting me. I really appreciate it. Really excited to be here.
Thank you so much, Mr. Ahmed Hashmi. And now I'd like to request Mr. Awais Mir, the CEO of Dynamic Groups and Dynamic Medical Company, to offer the vote of thanks and give us closing remarks. Thank you so much.
अगर आप ये एग्जिस्टिंग जो फैसिलिटी है या लाइफ डिनाइज में क्या आप हमें इतनी नेक्स्ट बना के दे दें तो जो डीमोडिफाइड सेल ब्रेन जो जिसमें यूनिवर्सिटी सिंगापुर के साथ हमारे आईआईटी के साथ में ज्वाइन करके बहुत शुक्रिया दैट वाज वर्किंग स्टेट ऑलरेडी जनवरी में हम दे रहे हैं तो हमें जो हमारे रिएक्ट कैंप कर रहे हैं तो कैंसर से या जो हमारे वो कैंसर जो वो इंशाल्लाह जनवरी में आपको जहाँ पे आपको निकाल के जा सकते हैं आपको सीपीएस बना के
आपको क्या बना
सीपीएस सपोर्ट तो देगी लाइक ना कंट्री में रिसर्च में चाहना चाहता था तो चैनल को हमारे बहुत ही आपको अप्रिशिएट करते हैं आप एनवायरमेंट होगी आप सपोर्ट देंगे तो तभी आगे हम जाके भी कुछ करेंगे अगर मैं तो आपको देता हूँ जी मेरे वाइट सेल ट्रेन यूनिवर्सिटी सिंगापुर के साथ गए हम आगे पाकिस्तान हो चुकी है अगर आप चीन की रेट जहाँ पे स्टेटस करके दे दें तो आप किसी मोड पे आपके साथ तैयार है और जनवरी फरवरी में आपको सेंटर में जाएंगे और यहाँ पे अच्छा एक तो है सर दूसरी आपका जो लाइक फॉरेन भी होते हैं एक पेशेंट की $20,000 $25,000 देना वो चार्ज सकते आपकी अपनी जो चार्ज है वो $5,000 आपका जो खर्चा है उसकी जो एक्सपेंस आ रहे हैं वो $25,000 और $25,000 $30,000 बिना फॉरेन जो पेशेंट आए उसको जो है ना उससे आपकी मार्केट भी अलग हो जाएगी आपके मेडिकल यस लेकिन दुनिया नॉन वायरल बेस की दुनिया में अभी काम नहीं हो रहा नॉन वायरल बेस की बॉडीगार्ड से हम यूनिवर्सिटी के साथ काम कर रहे हैं मेडिकल हो चुका है अभी आप जहाँ के गवर्नमेंट हमें सपोर्ट करें चीन की रेट बना के दे तो हम उसको कर सकते हैं like six preparation days. हम एक गवर्नमेंट बना के दे रहे हैं, तो हमारे यहाँ पे बहुत सारे क्लास दे रहे हैं, हम उसको क्रैश करके हम सिर्फ बना रहे हैं, हम इसको कर सकते हैं, हमारे अभी बहुत सारे केस हैं।
So he's referring to GMP labs.
हम टेली मेडिसिन से हमारे एक IT डिपार्टमेंट है, गवर्नमेंट है उसके हमें सपोर्ट दे रही है, तो इक्विपमेंट हम बात से लगे आप एक और बना के आप
इंस्टॉल की जनरेटर so let us get over के आप dictate करें and then come up with a name whether you want to tell EdTech facilities or HealthTech, biotech, go off technically.
बाद में ले सकते हैं। हमने जापान के साथ ये भी स्वागत जो है ना मैं जापान से लेके यूपी दुबई में एक एग्जीबिशन में वहाँ से ले पूरा हम से लेके दुबई में ना पांच साल का हमारी क्या वहाँ के सेक्टर सारे में और लाइक उसने बहुत बड़े हम काम कर रहे हैं वहाँ पे हम जा रहे हैं वहाँ भी जैसे स्क्वाड स्टेशन स्क्वाड काम होते हैं अगर आप जाते हैं तो फेस पेपर तो 10 साल नहीं आता आती है तो प्रॉफिट जो है हम पाकिस्तान लेके आ सकते हैं लेकिन देखिए एग्जीबिशन में सपोर्ट हमें दे हमारे यहाँ की बिजनेस कम्युनिटी बहुत यहाँ की टैलेंट है उसकी प्लेटफॉर्म हम भारत के गौरव जैसे सेक्टर दुनिया में बहुत ज्यादा है अगर जैसे प्रोडक्ट हम दुनिया में बेची काफी राशि मिलते लेके आ रहे हैं तेरी मेरी फैक्ट्री और जितना भी ट्रांसफर जो है ना आपके साथ है ना हमें सपोर्ट करें और विदिन 1 ईयर में आपको इसका कुछ हो जाएगी आप एक बार की इंडस्ट्रियल है जेनेटिक्स में आप 6 मंथ है आपका जेनेटिक जो डेट है कमर्शियल स्केल पे आप दुनिया को देख
Thank you, Mr. Altaf, for your shukriya. And now, Mr. Awais made the closing remarks. Thank you.
Gee, thank you very much. Again, assalamu alaikum to all. Especially Vice Chancellor Dr. Shahad, his team. Thank you very much as always. The more perspective and one and all Chairman FCZA, Chairman and Mr. Dr. Razna and all the team and the DA team who've been there. Okay, my closing speech is something I will be a little bit unorthodox because I don't believe in speaking. For me, when the last ex-Prime Minister was there in one of the conference which Yusuf was there in the one-to-one meeting, one of the Chinese stood up and said, although he owned the Marine airline, he said, "Sir, the only thing which we see the difference in your conference or your exhibition is that one tagline is grossly missing, which is action speaks louder than the words." So what I will say, well, that I would like to take away what is was in it. Actually, from where all this thing comes in. It comes from the initiative that this conference, or what we call it, has from the starting point, what Dr. Shadal said, it's just the beginning. It's the beginning starts with the awareness. It's the beginning starts with how we will take the genomics thing, what we mainly focus upon, health tech technologies, which is for us, is based on the AI technology method, and change the whole holistic approach of public health. As Mr. Chairman just mentioned, that we have a facility, there is like 4 decades or more than 5 decades. So obviously people here in our country, they always have a vision, whatever is gone, whatever be still there. But actually that vision has never been transformed into the real integrated actions. How I see that beside the government targets, the curability, the cancer diagnostic one, the kind of diseases and the diagnostic phenomena, what we had it and what was since the last 2 years after this COVID breakdown, obviously Mr. Chairman and Dr. Shahzad know that healthcare is not my cup of tea. I'm an energy professional, specifically on oil and gas, but that drives me looking towards healthcare, that when I see the opportunity, when I go into the deep dig of it, there's an humongous gap. And I can tell you the humongous gap drives with our own due diligence, what we done in the last year and two, that the pharma companies, which are basically one of the driving force, the genomics and what just Dr. Oscar just mentioned about the testing facilities or the preventive thoughts, which has to come from our pharma industry, is grossly missing. You will correct me, Dr. Shahzad, if I'm wrong, because when I talk with them about the genomic, the national imaging technology, and when this whole drive starts with actually with the STZA, when STZA was in making just a year ago, that this project which we discussed, NewSoft, was the national imaging one. They wanted to start with the both manufacturing units and then export over there. But then we need to disintegrate in the stage 1 and stage 2, because the stage 1 over in the public health doesn't actually exist. Like I give an example of the district headquarters and the driver of Mr. Chairman or Dr. Shahzad, if he has to do an angiography, even if it's used in this, he has to wait like for more than a couple of months to get it. And by the time he there mein bata hi mat jaye. So our curability ko to what we call it ke chhod dein, ya to basic facility in this. And why? And I'm a little bit blunt in terms of, because now it's a time of bluntness, because of the situation we had it, that it's not just all the government, it's the private sector which will are equally responsible of what is the missing gap, which is an energy entrepreneur standing over here trying to close the healthcare health tech conference in a way that when I talk with the pharma company to join us the hand in the genetic lab, he said, "Ye aap kaun sa manjan bechne aa gaye ji? Where with genomics, healthcare, why should we bother? We send our thing to our Khan, they send it to any of friends of Dr. Ghaznas, of the top-notch doctor. They give it $3,000, $4,000 into this, like koi garib yahan pe aapke ko saal mein jaake 50,000 ka khana kha leta. So he don't care for having a CT scan or MRI to be done, chahe wo 50,000 mein hoti hai ya PET scan 1 lakh mein hota hai. So with that said, what boil it off? Coming back, main zyada detract nahi kar raha, but coming back, what the whole concept is, after me coming with the HSA, courtesy of Dr. Ghazna, I strongly feel that the HSA, and I really like to commend Dr. Shahzad's vision, because the kind of a man he is, kind of a phenomena would be. Right now in this stage, the kind of a discussion we were having it, not only who hota, NIH hota, or HA hota, it would be all the ministries, although I don't bother about the government, as I said, equally private responsible है इस उस पे, क्योंकि जिसको 50% की इस मुल्क में IRR मिल रहा है, why should he bother to set up a medtech or a vision of Mr. Chairman, what he explained it over there? Because वो तो चाहता ही नहीं है कि medtech बने, वो तो चाहता है कि एक Gates और एक GE सारे 50 सालों से रहें और हमारे मुल्क में 250 मिलियन की mobilization क्यों हो for this point. And so with that said, ये बड़ी छोटी सी effort है, it's J awareness, but since I take it as not only just a commercial proposition, I strongly believe that this thing is, it's a daunting task to have it over there, which has never been able to do this. But what I'm trying to integrate is to bring our Chinese friends from the starting point, and now that we are packaging with our people, with just like a TCP, who is being already working then, and they have a concept of awareness. So in short, what I say that this conference is all about promoting the awareness of the genetics. We try to cover the masses and the general public, how they can have it cover up in terms of the trickle-down effect, and then what figure it out. Hardly any conference you will see the whole world be covered in the last 3 hours, from all the way from Korea to Finland over there. So they eventually, what we say, just say, Mr. Chairman, given the quote always to the Quran, what we added, कि कोई आपकी मदद तब करेगा जब आपकी अपनी मदद खुद करना चाहते हैं. So when I had a call to the Prime Minister office, this is a conference you have to attend or the minister. But अगर यहाँ पे मीडिया ने मिनिस्टर को देख के आना है, just to give an example, rather than to one application and entrepreneur. So this mindset, and I'm saying it in the last, that awareness comes with the attitudinal change. If we have an attitude towards the development phenomena or taking this country to the next level, we all have to change our attitude from the chairman to the manager, to the journal, to the clerk, or to the peon working in my office. So in short, again, we've been doing a one national imaging technology project in which phase one, we say HSA and the MOH is our counterparty. We in the phase two, we are trying to build a CKD for which STZA is our counterparty. We are already in the application of it, and to kickstart something courtesy of the structure which Dr. Ghazna mentioned about the BGI. So we are trying to build up deployment over here in the technical institutes, in academia, which are again the missing point of grossly linked with the commercial phenomena. यहाँ प्रोफेसर आते हैं और कॉन्फ्रेंस में बैठते हैं और बेचारे अपने नोट लिख के चले जाते हैं बिकॉज उन्होंने कहा कि उनका किसने सुनी है, जैसे अभी चेयरमैन ने बांग्लादेश की मिसाल दी. So this is what we are trying to change the recipe for the change in, and we feel that this can only be possible if we use our existing phenomena as what Dr. Saira asked. Okay, how do you see the importance of the data? So these 250 million is our strength, not just the strength of in Jazbe mein to put us ready for the war. कि आपने जंग होना है तो आपने तराने खा के वो करने, but to have a jang or jazba in ourselves to get the change in our mindset, our attitude, or our vision with the ultimate goal to take the prosperity of this country to the next level. So in short, again, thank you very much, Dr. Shadar. I should say, whole DEA team, which put tirelessly effort from Shiraz and the company, Chico, the Tina, and then the rest of the team of TCP who worked also tirelessly with us. And of course, the HSA team, especially Moin and this and Dr. Taira will make this all successful. So we hope that this will make a new start in the health tech and med tech together. So again, thank you very much.
Thank you very much, all of you, for joining us today. And अपनी रिश्ते की शम्मा को जलाते जाते हैं. बहुत शुक्रिया. पाकिस्तान जिंदाबाद. अल्लाह.
Thank you, Mr. Mayor.
Thank you, sir.
We need to distribute the shields first. So there is a statement of thanks in the distribution of shields.